Welcome, everyone. We are delighted that you have joined Parkinson Voice Project for our research, intent, and teletherapy webinar. My name is Samantha Ellendary. I'm the founder and chief executive officer of Parkinson Voice Project. First of all, I want to thank our board of directors, our staff, and our very generous donors who have made this webinar possible. Copies of today's handouts were emailed to all the registrants this morning. Please check your spam folder. If for some reason you did not receive the handouts, please email grants@parkinsonvoiceproject.org and we will email you the handouts after the webinar. But hopefully you have already received them. They were emailed this morning. We have a couple items to go over. First of all, if you have any questions, please use the Q&A feature. Please do not use the chat feature. Use the Q&A feature, and I ask that you include your email address with your question. Just in case we run out of time and we're not able to get to your question, then we will make sure to email you. Also, attendance is being tracked during the webinar, and a survey will appear at the very end. In order to receive ASHA CEUs, you must complete the survey when it pops up at the end. The survey will not be emailed out to you later. You have to complete it at the very end if you're wanting to secure ASHA CEUs. And if you are an international grant site that was not able to join us live, and you'll be watching the recording, then I'm sorry, ASHA CEUs are not available for the recording. Today we have three wonderful speakers, very excited about this. Our first speaker will be Dr. Allison Behrman. Allison is an associate professor in the Department of Speech, Language, Hearing Sciences at Lehman College, City University of New York. After Dr. Behrman's presentation, we will take a 15-minute break, and then Dr. Richard Drake will be our second presenter. He holds the rank of professor in the School of Communication Sciences and Disorders at the University of Central Florida. Both Allison Behrman and Dr. Richard Drake are volunteer members of Parkinson Voice Project's Scientific Advisory Board. After Dr. Drake, we will take another 15-minute break, and then our final presenter is Gwen Nolan. She is Parkinson Voice Project's Clinical Outreach Coordinator. Prior to joining Parkinson Voice Project, Gwen worked in several medical settings, and she was an assistant clinical professor at the University of Missouri, one of our grant sites. And so she was the primary SOP at that grant site and got the program going. All right, we're ready to start with Dr. Behrman's presentation. You're going to really be impressed. Here we go.
These three components are all equal. I'm very pleased to be able to bring you this presentation on the research evidence for Speak Out and the loud crowd. Evidence-based therapy consists of obtaining the best possible research data combined with your personal clinical expertise as well as the specific values, characteristics, and circumstances of the patient who you are treating. These three components are all equally important. Research data is not more important than clinical expertise, and clinical expertise is not more important than the patient sitting in front of you. All three of these components are necessary for you to be confident that you are providing the best possible care for your patient. Thus, it is important for you to be familiar with the research on the therapeutic methods that you are using. In this presentation, we will examine the available research data. 6 published studies encompassing a total of 203 patients have all demonstrated positive outcomes. 1 retrospective study consisting of 78 patients, 3 small prospective group studies totaling 45 patients, and then 2 large prospective studies that we conducted of 40 patients. In 2016, Watts conducted a retrospective chart review of 78 patients who had had a total of 12 speak out sessions here at Parkinson Voice Project. Average intensity of sustained vowel phonation, reading, and conversation were measured at baseline, that is, before treatment began, after the 12th speak out session, and at 6 and 12 months after the 12th speak out session. This plot shows the result of the average intensity level for sustained vowel, the top blue line, for reading, the middle orange line, and for monologue, the bottom green line. Before therapy, right after therapy, and at 6 and 12 months post-therapy follow-ups. For all 3 tasks, the average intensity increased significantly from baseline to the immediate post-therapy assessment, and statistically significant improvement was maintained at 6 months and at 1 year. The reason that intensity is so much greater for sustained vowel compared to reading aloud or spontaneous speech is because people tend to sustain a vowel more loudly than they do read or talk spontaneously. And in addition, sustaining a vowel is one of the exercises performed daily, so patients had a lot of practice with that tasks. These 3 D values on the right represent a statistical measure of clinical significance. A value above 1 is considered a clinical significant finding. Therefore, 1 year after therapy, on average, patients maintained a clinically significant improvement in intensity. However, it must be pointed out that at 1 year, less than half the patients were assessed. The study started with 78 patients and completed with only 30 patients at the 12-month follow-up. That's one of the weaknesses of a retrospective study. A retrospective study means that analysis was conducted on data gathered for clinical, not research purposes, after all the data was gathered. So while retrospective studies are interesting and suggest outcome status, they are not a well-controlled or valid or as valid as prospective studies that are designed ahead of time, and data gathering occurs under much stricter conditions. Let's look at the reading and monologue intensity data from Watts' study compared to healthy individuals, that is, neurotypical subjects. The healthy data, represented by the dashed lines here, comes from a Ramig study in 2001. You can see that the Parkinson's patients in Watt's study, the solid green and orange lines, had lower intensity at baseline for both reading and monologue tasks compared to the healthy individuals, and that's not surprising. Immediately after therapy, and in the 6-month follow-up, the intensity of the Parkinson's patients was at or above the average intensity for the healthy speakers. That's rather impressive. We can also compare the data from the Watts study with the data from patients who received LSVT as reported in Dr. Ramig's 1995 study. For the reading and monologue tasks, patients receiving Speak Out, the solid orange and green lines for reading and monologue, respectively, had average greater intensity than the corresponding tasks from patients receiving LSVT, the green and orange dashed lines. Now, comparison of data across studies of different treatments is tricky because conditions are very different in the different studies, and these studies were conducted 20 years apart, so data gathering instrumentation was quite different. However, the comparison does suggest that the Speak Out therapy appears to provide as positive an outcome as LSVT and with fewer number of treatment sessions. In an interesting study conducted by Levitt and her colleagues in 2015, 12 patients were assessed at baseline and after 12 sessions of Speak Out and after 4 and 8 sessions of the Loud Crowd. This is a prospective study. Intensity of sustained vowel phonation was examined, but most interestingly, vowel articulation was also examined, extracted from reading aloud a standardized sentence. Patient perception of voice was also assessed using the voice-related quality of life scale. Let's look at the findings. A significant increase in intensity was found after Speak Out for sustained vowel phonation, blue line, and also for average intensity of the ah vowel extracted from the sentence from reading aloud, the orange line. These increases from pre-therapy to post-Speak Out to post 4 sessions of the Loud Crowd to post 8 sessions of the Loud Crowd, these increases were maintained. In Levitt's study, examination of the E, ah, and oo vowels showed a significantly larger vowel space after therapy, the red triangle, measured by the average frequencies of the first and resonant second formants of these 3 vowels compared to pre-therapy, the dashed blue line. Now, I'm sure formants were your favorite topic of study in speech science when you were back in school. But just to refresh your memory, what this chart implies is that the range of motion of the articulators, the lips, the tongue, and the mandible were greater after therapy. That is, the patients were moving their mouths more during speech after Speak Out in the Loud Crowd, suggesting greater clarity of articulation. That is an impressive finding. Patient perception of voice was also measured in the Levitt 2015 study using the 10-question voice-related quality of life scale, in which numbers closer to 100 reflect a very positive viewpoint. At baseline, the average perception of vocal function at 71 was poor. A score of 71 is not good. A significant increase was found immediately after Speak Out and the Loud Crowd to 87, and the higher numbers after Speak Out and the Loud Crowd were maintained. This is interpreted to mean that patients perceive their voices to have greater functionality in their daily lives after participation in this program. That's good. Okay, I'd like to tell you about two prospective studies conducted by myself and the team here at Parkinson Voice Project. In the first study, we examined the short-term effect of Speak Out and the Loud Crowd. This study was published in 2020 in the American Journal of Speech Language Pathology, ASHA's major clinical journal. This study was done in collaboration also with our statistician, Dr. Flom, and also Dr. Chipness, who is on the Parkinson Voice Project Advisory Board and as a neurologist here in Texas. This study was funded by a grant from the National Institutes of Health and by private donor funding from Parkinson Voice Project. And of course, it had Human Subjects Institutional Review Board approval. Patients were enrolled in this study who were diagnosed with idiopathic Parkinson's disease and who were referred to Parkinson Voice Project for speech therapy by their neurologist. Participants were excluded from the study who had deep brain stimulation or who had had any speech or voice therapy within the past 2 years. All of the inclusion criteria are listed on this slide. Okay, this graphic shows the basic structure of the study. Lots of little boxes. Let me just walk you through it briefly. In the upper white boxes on the left, it shows that participants had 3 baseline assessments within approximately 2 weeks before they started therapy. Why 3? Well, that was to establish a stable baseline for comparison after therapy. If we just assessed them once, maybe that was one bad day or one good day. So we wanted a stable baseline. Next, shown in the orange boxes, participants had 12 40-minute individual speak out sessions 3 times per week for 4 weeks for a total of 12 sessions. Then participants participated in the loud crowd shown in the green boxes on the right. Participants were encouraged to begin the loud crowd just prior to completing the speak out sessions. Why? Well, this was done to emphasize to the participants the importance of the loud crowd and that the loud crowd is an integral component of the entire therapy process, not just an elective add-on. That's important. Outcomes assessments, kind of highlighted here in the white boxes, were conducted 3 times at baseline within 1 week of completing Speak Out, the 12th Speak Out session, and then again 5 weeks later. Data from 2 speaking tasks were measured in the assessment. A monologue of about 1 minute on a topic such as a recent vacation or similar topic they were familiar with, and reading aloud, a short modified paragraph from the Caterpillar passage developed by Dr. Patel and colleagues in 2013. This passage was designed specifically to assess prosody, that is, intonation. We edited it to make it a bit shorter. And we added a sentence at the beginning. We were away a year ago, and I'll explain the reason for that in just a minute. We assessed 3 acoustic variables from the monologue and the reading: intensity in decibels of sound pressure level, which answers the question, how loud is the patient talking? We assessed voice quality using cepstral peak prominence, which answers the question, how good is the patient's voice quality? This measure, cepstral peak prominence, measures the harmonic energy and the noise level of the voice. It was measured from the first sentence of the reading passage that we added on. We were away a year ago, which has all voiced sounds, and research by Dr. Patel and colleagues shows that it is recommended for calculating a valid and reliable measure of cepstral peak prominence. And we measured intonation using the standard deviation of the fundamental frequency. This question answers how much vocal variety, variability in pitch, intonation does the patient use? We also assessed patient perception using the 10-item questionnaire, voice-related quality of life. This measure answers the question, how well is the voice functioning for the patient, using the patient's opinion, on average, over the prior few weeks. Okay, this graphic shows how many patients were enrolled in the study and how many completed the study. Our statistician conducted a power analysis. That's a statistical measure that tells us how many subjects are needed for a study in order to be confident that the outcomes reflect a large group of individuals with similar characteristics. It was calculated that we would need approximately 40 subjects. So we kept assessing patients till we had the right number of subjects. We assessed 166 patients, of whom 47 met the enrollment criteria and agreed to participate. You have to assess a lot of people to get the number for your study. The remainder didn't want to participate or didn't meet the inclusion criteria. Most commonly, they had other complicating neurological diagnoses or had had speech therapy within the prior 2 years. While it is critical to assess the effect of therapy on these other groups of patients, you can't assess everybody at once. It makes assessment very complicated. You need to do studies in stages. So for this first large, prospective, statistically valid study, it was important to limit the type of patient so that we could assess the effects clearly. Of the 47 patients who were enrolled after completing, of the 47 patients who were enrolled, 41 completed Speak Out. The other 6 dropped out during therapy. And as speech pathologists, we know that happens. Some patients stop coming to any type of therapy. 2 patients decided they didn't want to have to go through 3 baseline assessments, and 4 patients dropped out during therapy, due to the disease, due to traveling, due to other factors. At the 6-week follow-up, after the final follow-up for our study, after completing Speak Out, only 1 participant didn't come back for the final assessment. So we were able to completely assess 40 patients. Yay. Strong statistical study. The 40 patients that completed the study consisted of 15 women and 25 men. Interestingly, that male to female ratio is generally what's reported in the literature for prevalence of patients with Parkinson's disease. We also assessed 20 healthy age-matched controls on the same assessment schedule as the patients, the difference being the healthy subjects did not participate in any therapy. The reason we assessed the healthies is that in this way, we could make sure that any change observed in the patients after therapy was due to the therapy and not some other random factor. That is, if the healthy control subjects showed no significant change, then we knew it was the therapy that was making the difference in the Parkinson's patients and not just, for example, the process of being assessed multiple times. They were our control group. Okay, now for the interesting part, the results. Okay, many of the results are shown in box plots, so it's important that everyone understands what a box plot represents. In this example, the box is located at a specific point in time, and on the y-axis are values of some measure, whether it's voice, related quality of life scale or acoustic measure, whatever. The box represents the values of some outcome measure from each individual at some point in time. So we take all of these measures and we get the average measure for each patient and we throw them into this box. So this box is all 40 patients. Let's say it's each patient's intensity level during reading at baseline, okay? The lower border of the box represents the 75th percentile of scores. The lower border of the box indicates the 25th percentile of scores, and the upper border of the box represents the 75th percentile of scores. So 50% of the scores are within this box. The straight lines above and below the box are called whiskers and represent the 10th and 90th percentile of scores. And the dots up and below the whiskers are considered outliers, that is unusual scores. And there's always an unusual score too in a group. The horizontal line in the middle represents the median. That means half of the scores are above this line, half of the scores are below the line. These types of plots are basically these distribution curves that we're all used to seeing. It's just a distribution curve turned on its side. So box plots provide way more accurate information about the spread of scores than do simple bar charts. Bar charts are not appropriate when you're looking at average data of many subjects in a group. So we're going to look at box plots. Okay, now we're ready to look at the results. Here are the results for intensity. On average, how loud were the voices of the group of patients and the control subjects at baseline, at 1 week after speak out, and at 5 weeks after speak out? All of the gray boxes represent the intensity level of the Parkinson's patients when reading. All of the red boxes represent the intensity level of the Parkinson's patients during monologue, spontaneous speech. Recall that we assessed everyone 3 times at baseline. And once at 1 week and once at 5 weeks after therapy. Note that at baseline, there's very little variation for the gray boxes, the reading, and only a little bit of variation for the monologue. And you expect a little bit of variation. That's why it's important to assess multiple times at baseline, because then we can compare post-therapy with an average value of the 3 baseline measures. Look to the right now at the after therapy scores. You can see a significant improvement in intensity from 70 or below to 75 to 80 dB. And don't forget, decibels are on a logarithmic scale, so a couple of decibels makes a big difference. You can see significant improvement in intensity in both reading and monologue immediately after therapy and 5 weeks later. Reading aloud was consistently louder than monologue, which is to be expected. People tend to speak more quietly in spontaneous speech, in one-on-one conversation in a quiet therapy room than they do when they're reading aloud. And then this gray bar, blue bar, whatever color you want to call this, going across represents the average value of the healthy controls. We hypothesize that the improvement in intensity when speaking with intent was likely due to improved phonatory glottal closure, that is, the vocal folds closed better during each cycle of vibration when speaking. That would allow for greater buildup of lung pressure, that is, subglottal pressure below the vocal folds, so more air is going into that acoustic pressure wave up and out the vocal tract when speaking. And that is the major regulator of intensity, loudness. Of note, for both speaking tasks, after therapy, intensity levels fall within the range of intensity obtained for healthy controls. Wow, that's really cool. Okay, this box plot shows the results for Kestrel peak prominence, the acoustic measure that answers the question, how good is the patient's vocal quality? In this plot, the red boxes now represent the women, the gray boxes represent the men. The grayish blue bar still represents the healthy control. And the red, I should specify the red and the gray boxes here. These are the men and women with Parkinson's disease. Again, note at baseline, pretty stable measures. At 1 and 5 weeks after therapy, Kestrel peak prominence was significantly increased for men and women. Compare these results to the healthy controls, this horizontal bar here, and you'll see that for the male participants, voice quality is close to the range of normal. For the women, voice quality exceeded that of healthy controls. Okay, recall that the healthy controls are age matched for the patients with Parkinson's disease. Thus, voice quality overall would be considered on average to have characteristics of presbyophonia, even for the healthy controls. They were older people. We hypothesized that the improvement in voice quality for the patients was likely due to improved phonatory glottal closure. Again, this is coming up when speaking with intent, which would produce stronger harmonic energy in the vocal signal. Less noise, more of the good stuff. We further hypothesized that the women's voices improved more than that of the men's due to gender-based differences in spectral characteristics of men's and women's voices, particularly with presbyophonia, with aging. The third acoustic measure we assessed was intonation, sometimes called vocal variety. It is the main characteristic of prosody. We measured intonation as the variability or standard deviation of fundamental frequency around the average, around the mean, for each individual subject. Here are the results for intonation from monologue. Men with Parkinson's are represented by the gray boxes. Women with Parkinson's are represented by the red boxes. Healthy men by this lower gray bar, gray-blue bar. Healthy women by this upper gray-blue bar. Note that at baseline, the values are pretty stable among the men and again among the women. Little change. At the 1 and 5 week post-therapy assessments, a statistically significant increase in intonation was noted for the men and for the women. At baseline, the women started out with greater intonation than the men, and after therapy, the women had a larger intonation gain, than did the men. Now, part of this is due to the tendency for women, on average, to use a wider intonation pattern than men. But also, part of this is due to the fact that women have a higher fundamental frequency, that is average pitch, than men, and that affects the calculation of the standard deviation to a certain extent. But the important thing to note is that both men and women had a statistically significant increase in intonation. They used greater vocal variety after speak out. The blue bars represent the intonation for the healthy men and women. At baseline, the men with Parkinson's use significantly less intonation than their healthy counterparts, and the women use significantly less intonation than their healthy counterparts. And again, we expect that. It's a characteristic of Parkinson's disease to have mono pitch. After therapy, both the men and the women with Parkinson's used an intonation pattern consistent with their healthy age-matched counterparts. That is impressive. Okay, for those of you who love statistical analysis, I don't want to disappoint you. So this chart shows the 3 acoustic outcome measures for decibels of sound pressure level, Kestrel peak prominence, standard deviation of the fundamental frequency for men and women combined in reading and monologue for intensity, and for men and women broken out separately for reading and monologue for Kestrel peak prominence and standard deviation of the fundamental frequency. And the stars represent statistical significance. And these are the statistical measures. Okay. Our study of 40 subjects also examined patient perception of voice using the voice-related quality of life scale. Our data shown in the first line of the chart on our 40 subjects indicate that the baseline average scores of the participants for Parkinson's was about 70, not good. And at the second post-op measure, mean scores were 84. The improvement from 70 to 84 is statistically significant and consistent with improvement in the other smaller studies of Speak Out we discussed earlier. Scores from healthy control subjects, from the 20 healthy controls from our study, are shown in the bottom row and are close to 100 for both time point measurements. Therefore, we note that after therapy, the patients with Parkinson's disease did not consider their voice to function as well as healthy individuals. And that's not surprising. They still had Parkinson's disease, but they did find significant improvement. Our study did not compare Speak Out with LSVT Loud. It's really complicated to run a 2-therapy randomized controlled trial. However, we can take a look at the published data on LSVT and compare it to our published data. And we're looking at data from Dr. Ramig's study from 2018. Here is a simple line plot showing intensity at baseline and at approximately 1 month after therapy for monologue in red and reading aloud in blue. Data from our study showing patients receiving Speak Out is in the solid lines. Data from Dr. Ramig's study of patients receiving LSVT Loud is in the dashed lines. Note that the intensity gains are quite similar between baseline and post-therapy for the 2 therapeutic approaches. Now, because these data are from 2 different studies, again, we can't overanalyze them and compare small differences at baseline and at endpoint. We just generally look at the overall gains. Our results are quite impressive. They suggest that Speak Out, which requires half the number of treatment sessions as LSVT Loud, is equally effective. Wow. Okay, finally, I'd like to discuss our second prospective study in which we evaluated the 1-year outcomes of Speak Out and the Loud Crowd. The manuscript describing this study is currently in review in the Journal of Logopedics, Phoniatrics, and Vocology. That's the Journal of the British Voice Association, and it's widely read in Europe. This study followed the same cohort of patients that we just discussed regarding the immediate short-term outcomes. We reached out to these 40 subjects who completed the 6-week follow-up. We reached out to them 1 year later. And I'm delighted to report that 35 of the patients were reachable and agreed to participate in the study. The other 5 patients either weren't reachable or didn't want to participate anymore. That's really good to get that high a percentage of patients to participate in a follow-up a year later. It's critically important to understand the efficacy of our therapies over the long term. That's why this study was so important to conduct. All participants with Parkinson's participated in the initial 12 Speak Out sessions, but all the patients, those 35 patients, did not participate in the Loud Crowd every week for the year. On average, the 35 participants that we followed at 1 year out attended 21 sessions of the Loud Crowd over the course of the year, with some attending as few as 0 and others attending as many as 31. The standard deviation of 13 means that there was moderate variability in the number of sessions attended across all 35 subjects. This information about the number of the Loud Crowd sessions attended will become quite relevant in a few moments. Okay, let's look at the results of this 1-year study. These plots show the results for intensity in monologue here on your left, and intensity in reading here on your right for the men and women with Parkinson's. The gray boxes in each plot represent the average baseline values across those 3 baseline measures. The middle striped box in each plot represents the intensity at the second assessment after Speak Out therapy, the endpoint of the study that we just previously discussed. And the solid blue boxes are the new information. Those represent the intensity values at 1 year after therapy for the patients with Parkinson's disease when talking spontaneously and when reading aloud. The main values of intensity at 1 year were the same as at 6 weeks after therapy. That is, statistically, there were no differences found on average in the group mean data. That is really impressive, particularly when you consider that the patients remained with Parkinson's disease and some even progressed in their disease. They still maintained speaking with intent and being louder. These plots show the results for intonation, vocal variety, in monologue on your left and in reading on your right. You can see significant improvement from baseline to post-therapy to 1 year out for both speaking tasks. That is, Patients with Parkinson's disease were continuing to use significantly greater vocal variety 1 year after Speak Out compared to before therapy. Again, impressive results for speaking with intent 1 year after therapy. The graph on your left shows the results for Kestrel peak prominence extracted from the sentence "We were away a year ago." As you can see, there's significant improvement from baseline to right after Speak Out to 1 year later. That is, patients with Parkinson's disease were continuing to have significantly clearer voices using speaking with intent 1 year after Speak Out compared to baseline. The graph on the right shows the results for the voice-related quality of life scale, answering the question, how well does the patient perceive his or her voice to be functioning on average? As discussed earlier, a statistically significant improvement in scores was found from baseline to immediately post-Speak Out therapy. However, you can see from the spread of the scores, the length of the box and the whiskers, that there was a lot of variability in perception of voice among the patients at baseline, with stronger perception of improvement immediately after therapy and less variability. At 1 year out, no statistical significant difference. This perception was maintained, although a little more variability was present. Now, I should point out that assessment of patient perception of voice with this patient population is tricky. One characteristic of Parkinson's disease is poor awareness of speech deficits. Therefore, with therapy, one has to ask the question, do patients become more aware of their deficits and therefore rate their vocal function worse as a result, even though the voice has actually improved? Or are they more aware of the deficits, but they're still feeling that their vocal function is improved, so it's better? It's a very complicated topic. It's difficult to know, and it requires a study unto itself. Okay. Recall that I had said the information about number of the loud crowd sessions attended during the year would be very important. Okay, we're at that finding now. Let's look at how important attendance in the loud crowd really was. First, however, I want to make sure that we're all comfortable examining correlation relationships. What's a correlation? It shows us how one variable changes as the other variable changes. So the imaginary, that is made up correlation on the left, shows how the grade of a student in school, first, second, third, fourth, whatever, relates to their age. It shows that the higher the grade, the older the age. Okay, a very strong correlation, not exactly stop the presses, world incredible news. We could say here that grade predicts age. And we can conduct statistical analyses to measure the strength of this correlation. However, in the real world, correlations this strong are rare because human beings are, well, human, and we all have lots of variation. In contrast, the pretend graph on the right shows very poor correlation between people who enjoy ice cream and people who are good at sports. The line is just straight across and the dots are all over the place. Okay, again, no surprise. Now we're ready to look at the correlation of attendance of number of sessions in the loud crowd and our outcome measures. Ta-da! Okay. Each of these 6 graphs represents the correlation between number of sessions that each patient attended of the loud crowd over the course of the year and an outcome measure. So let's look at these individually. The top left graph shows intensity in monologue, and the bottom left graph shows intensity in reading. The gently upward sloping line in each graph shows that in general, patients who attended more sessions of the loud crowd during the year maintained greater intensity at 1 year than patients who attended fewer sessions of the loud crowd. In other words, greater attendance in number of loud crowd sessions predicted greater intensity in reading and monologue at 1 year, and the results were statistically significant. The top middle graph shows scores of standard deviation of fundamental frequency, that is intonation or vocal variety, at 1 year in monologue on top, and the bottom middle graph at 1 year in reading. The upward sloping line in each graph again shows that in general, patients who attended more sessions of the loud crowd maintained greater intonation at 1 year, not as much in reading as in monologue. Excuse me, not as much in monologue as in reading, but still, both correlations were statistically significant. The top right graph shows cepstral peak prominence, the acoustic measure of voice quality. Again, the upward sloping line shows that on average, greater number of the loud crowd sessions predicted maintenance of better vocal quality. The lower right graph shows the correlation between number of sessions attended of the loud crowd and the voice-related quality of life score here on the lower right. This was the only correlation that was not statistically significant. That is, patients who attended a greater number of sessions of the loud crowd over the course of the year did not generally maintain higher scores. Remember, their scores didn't drop, but they didn't improve. Okay, recall that I mentioned earlier that self-assessment of perception of voice in patients with Parkinson's is really complicated due to the frequent impaired sensory perception. Okay, once again, we can compare our data with data published on LSVT Loud, and here I'm using data from Dr. Ramig et al.'s 2018 study. This line plot shows intensity, decibels of sound pressure level at baseline, at approximately 1 month after therapy, and at 1 year after therapy for monologue, that's in red, and for reading, that's in blue. The solid line shows results from our study of patients receiving Speak Out and the loud crowd. And the dashed lines represent the data from Dr. Ramig's study of patients receiving LSVT loud. Note that the intensity gains for both types of therapy are quite similar between baseline and immediately post-therapy. More sessions are required of LSVT loud than of Speak Out, but the results are similar. However, look at the 1 year data. The intensity in reading, blue line, and monologue, red line, after Speak Out in the loud crowd is significantly greater. than for patients in reading and monologue 1 year out after LSVT loud. We hypothesize that this difference is due to participation in the loud crowd. We believe that ongoing participation in a group maintenance program prevented the loss of speaking with intent. It prevented the loss of intensity achieved immediately post-therapy, that was achieved immediately post-therapy, whereas there was a loss in intensity over the course of the year for patients who participated in LSVT loud. Again, interpretation across studies has to be done carefully because patient characteristic and treatment conditions are different. However, it makes sense given, and it's consistent with our hypotheses of treatment for patients with Parkinson's disease. It's consistent with data from other studies showing maintenance of physical activity gains and movement from those patients who maintain physical therapy and those don't over the course of a year, that continuing to participate in a therapeutic maintenance program, in our case, in a group session of the loud crowd on a regular basis, is critical for maintaining gains despite progression of the disease. Okay, in conclusion, I give you two big takeaways. First, Speak Out improves communication abilities for individuals with idiopathic Parkinson's disease. Second, the loud crowd is an essential component of the therapy for maintaining the gains achieved with Speak Out. Thank you so much for joining me in this presentation.
And thank you, Dr. Behrman. I want to let you know that our plan is to study these same subjects 5 years after, 5 years later. So that I can't wait to see those results. We were actually supposed to be measuring the patients 2 years post, but because of the pandemic, we were not able to gather that data. But we do have it set up to evaluate them 5 years later. We did have one question come in, which was, did these patients participate in refreshers? Yes, they followed the protocol just like we would with any other patient. We have just a couple minutes left. In a couple minutes, we're going to take a 15-minute break, and then Dr. Richard Drake will begin his presentation. I did want to share something fun with you. I don't know if y'all have heard of this, but we have a new Loud Crowd workbook. I think most of you know that I've been conducting online practice sessions, home practice sessions, since the pandemic started. We have lots of people joining us, over 1,000 people every day. And I put out a call for original tongue twisters, and we received over 100 of them. So we put together this book, and we're going to be selling this book. But if you are a grant site and your loud crowd groups are meeting in person, then you will receive some copies of this for free. And if your groups aren't meeting in person this year, then definitely apply for another grant. But we have just a minute. I thought I would read a few of these. They are amazing, and they're going to be so much fun for the loud crowd. So here is one. I better put my glasses on. Here we go. Particular Parkinson people pick their participles particularly. How many pickles can a professional pickle picking person with Parkinson's pick? With intent, a professional Parkinson's pickle picker can pick a pail of pickles pronto. It is so cute. Here's another one. Talking was tight, traumatic, tiring, and truly terrible till our smiling, saintly speech pathologist said, simple solution, speak out, saved. Aren't these adorable? And you really have to use a lot of intent. One more. If there is tension, when I mention my intention for attention. The invention of speak out is my pension for redemption. I'm able to speak with intent, so my voice will come out like I meant, not lost in a tent or bent with a dent, but clear so you know what I sent. It is so adorable and is going to be great practice with speaking with intent. All right, we're going to take a 15-minute break. If you did not get the email, please, some of the universities and hospital systems are blocking our emails. You need to check your spam folder or check with your IT department, because if you didn't receive this email, chances are you're missing other information that we're sending you, and we don't want you to miss out. All right, 15-minute break, and then Dr. Drake is up. Thank you, everyone. We're going to begin with Dr. Drake's presentation. Dr. Drake, I wanted to let you know if you started, we're not able to hear it.
I was just waiting for you to cue me to start.
Okay, thank you, everybody. Dr. Drake.
Good morning. Happy to be here today. Hope everybody's having a good morning. It's my pleasure to actually talk today about the neurophysiology of speaking with intent. I first became aware of the concept of speaking with intent when I was a graduate student at the University of Arizona in the 1980s, and Dan Boone was my mentor. And I remember him talking at the time, some 40 years ago almost, about speaking with intent and talking about how patients with Parkinson's disease, when they have more intentional movements, their speech improves. And when they have more intentional movements, their limb movements improve. And that always stuck with me. And when I started working as a clinician, I always remember the idea of the relationship between automatic movements and intentional movements. And so it was very rewarding for me over the years to see how that idea has just manifested itself, particularly through the Parkinson's Voice Project. And I was very fortunate to have the opportunity in 2016 to visit and meet Samantha personally and her staff and spend a couple of days there. And it was great. And I was actually thinking this morning, I can't believe it's been 5 years since I've been there, but I learned a lot from being there. And I teach this topic quite often in my graduate courses in motor speech disorders. As a matter of fact, I was just talking about it this morning. So with that wonderful background, let me go ahead and jump right into the topic of neurophysiology of speaking with intent. So the first thing that I want us to think about is, let me go over the disclosure. So I have the non-financial relationship is that I'm a non-paid member of the Scientific Advisory Board for the PVP. And I'm also co-author of the Voice and Voice Therapy with Dan Boone and Shelley Von Berg. So I wanted to start with a thought that life is a balance between rest and movement. So when you think about what we're doing, like right now, part of me is sitting and part of me is moving. Sometimes I'm not moving at all. I'm completely at rest. And other times I'm completely moving. And so when you think about a person with Parkinson's disease, there is this balance between them being sort of in a resting state and in a moving state. And we have to think about what happens when one transitions from a resting state into a movement state, particularly as it relates to speech and communication. So there's very much advantages to being sitting still. I mean, I wish I had more time to sit still, but there are advantages to that, just like there are advantages to moving. And so when you think about something like sitting still, oftentimes when we're sitting still, we're not talking, but it doesn't mean we're not listening. And I know I've had a number of Parkinson's patients who tell me that just because they're not verbally acknowledging what I'm saying to them, doesn't mean they haven't heard me. And I always remember that when I'm working with Parkinson's patients, to not assume that because they may have a more mask-like face or that they're not verbally responding to everything that I say, that they're not paying attention or that they're not listening. Movement, for me, helps me think. I mean, I do my best thinking when I'm standing in front of the class and walking around and moving. It's one of the challenges when we were in the pandemic and we had to do a lot of Zoom teaching. I couldn't really move around the classroom. I really enjoy that. It gets me thinking, it gets me motivated, it keeps me energized. And that's very difficult when you don't have the opportunity to do that. Walking for me also helps generate thoughts. So sometimes when I really need to think about something deeply, I'll just get up and take a walk. I'll walk around, the campus or walk around my neighborhood. There are definitely some advantages to movement from a cognitive standpoint, as well as from a speech standpoint. But that being said, we're all speech language pathologists or soon to be speech language pathologists. And probably one of the main reasons we like doing this field is because we get the opportunity to talk. And perhaps even more importantly and more rewardingly, we have the opportunity to help other individuals to talk and to communicate and to express their thoughts and emotions. So with that context in mind, I want us to take a minute and think about how do we become aware of what we're doing? Think about that. When you're doing something, are you aware of it? At what level are you aware of it? How much does that awareness change over the course of the movement? And these are deep philosophical questions, actually, that go back centuries. And so that's why I put these historical figures up. It's not something new that we're thinking about, in the 21st century. But I think it's an important question to consider. How do we really become aware of what we are doing? Because awareness speaks to one of the key tenets of the Parkinson's Voice Project approaches, which is to make patients more aware of how they're speaking so that that can influence how they change their speech patterns and their voice patterns. So think about awareness as it relates to movement. So let's talk for a minute about how this happens. So I have a thought to move. Could be to move my arms, move my legs, move my articulators. How does this actually happen? Well, there's a couple of things that happen. First of all, we've got sort of a dual process system taking place. First, we have the intention to move, and then we have the awareness of the movement. So if I want to type, then I'm aware that I need to type. I have this intention to put my fingers on the keyboard and to start typing. And then as I'm typing, I'm getting this tactile feedback through my fingers, up through my neurologic system to my brain, that's making me aware of how I'm moving. So I have the intention to move and I have the awareness to move. They're not the same, but they're interactive with each other. And so when you think about somebody who has Parkinson's disease and you think about they may have the intention to move, but they're probably not aware to the same degree that a normal speaker is about how much they're moving, or more specifically, how much they're not moving. So we're aware of that. Patients with Parkinson's disease are not as aware of movement, even though they have the intention to move. And you'll oftentimes hear this in conversations with persons with Parkinson's disease. They'll say to you, I think I'm speaking louder. I'm intending to speak louder. I'm intending to speak with more dynamics or more animated or more intentional, but they're not aware that they're not doing that at the beginning. And that's part of the process that we have to engage with them, is making them more aware of their movements. So a lot of the movements that we engage in are frankly, mostly unconscious, right? So if you're sitting right now in the chair, I would say to you, how aware are you of the position that you're sitting in? Like, do you know where your feet are? Do you know where your elbows are? Do you know where your wrists are? What position is your head in? You're not really thinking about it until I point it out to you or I ask you the specific question. So something like postural adjustments, whether they be standing postural adjustments, sitting postural adjustments, walking, things related to gait, most of it is unconscious. We just kind of go in this automatic movement pattern. It's usually very consistent, and we just don't become aware of it until something interferes with it. Same thing with visual scanning. I have teenagers right now who are just now learning to drive. I have twin daughters, and they just got their learner's permits. And so we're in the car. They've driven maybe half a dozen times each now. And they're having to more consciously do visual scanning for things that are ahead of them or to the side of them. Whereas I'm not nearly as purposeful and conscious of my visual scanning when I drive, because I've been driving for 42 years. But for the most part, visual scanning is at an unconscious level. When you're walking, you're just scanning what's going on around you so you don't trip and fall, but you're not actively aware that you're doing that. And then nonverbal gestures. Some people use a lot of nonverbal gestures. I do that all the time. I'm very aware of that. I don't even think about it. My hands just go with whatever my thought is that I have at the moment or the emotion I'm trying to convey. But again, most of the time, that is very unconscious. I'm not aware of it. Other people are aware of it, but I'm not aware of it. We can take automatic movements and make them intentional. So if you think about something like tightrope walking, right? So normally you'd just be walking along, and then all of a sudden, if I had you go up a ramp and go across a tightrope, you would be very aware of how you're walking and each step that you're taking. Same thing could be for gymnastics. I look at somebody like Simone Biles, and I think how amazing that is, that she takes something that is so intentional and makes it seem so automatic, right? And that's why she's the world champion. Same thing with animated speaking, right? So I can be talking now outside the hallway to a student, and then I come in here to do a webinar, and my speech needs to be more animated because I'm trying to project into the, into the computer monitor and hold your attention. Or I could be across the hallway like I was a little while ago, lecturing in an auditorium to a classroom full of students. Well, that adjustment that I make to either being here on Zoom or being in the classroom has to become intentional. It doesn't just happen. I have to think about how I'm projecting my voice and how I'm articulating my speech, and when I'm pausing and when I'm not pausing, and so on and so forth. Persons with Parkinson's disease their speech is automatic to begin with, like all the rest of us. And then when it needs to become intentional, the person with Parkinson's disease doesn't have the innate ability to make their speech more intentional. Likewise, they usually don't have the innate ability to make their movements, non-speech movements, intentional. So how is all of this mediated? Well, the basal ganglia, as you probably are well aware, the basal ganglia is very important in the mediation of movement. And just as a quick refresher, the basal ganglia are masses of gray matter embedded in the white matter, inferior to the lateral ventricle. So they are subcortical structures, meaning below the cortex. And they're situated in a way that they have connections to every other part of the central nervous system, particularly the brain. And that allows for input to the basal ganglia and information to go out the basal ganglia to other parts of the brain, which then can affect movement. And I'll elaborate on that in just a moment. But just think about the basal ganglia as key structures in mediating movement. Here's just a nomenclature. There's different nomenclatures for the basal ganglia. This is probably the most common nomenclature. Talks about the striatum, the amygdaloid body, and the globus pallidus. But as you can see, hopefully you can see my cursor here, you can see that the basal ganglia are situated, again, subcortically, below the cortex, but above the brainstem. You can see it on this view, and you can see it on this view as well over here. And these are very small structures. They're about the size of a walnut. So what do? Well, the basal ganglia help us make a selection of movements based on the information that's coming into us and based on the situation that we're in. So for example, we want to take movements like learning to play a musical instrument. Okay? When you're first learning to play a musical instrument, you have to be very intentional in what you do. You have to be very aware of where your hands are, let's say on the keyboard, and what fingers you're moving to play a certain scale. And that's very intentional. And the basal ganglia helps us to be able to learn how to do that. And eventually, with lots of practice, it becomes less intentional and more automatic. I've been playing the drums since I was 13 years old. So when I play a song, maybe that I've played 100 times or more, I'm not really thinking about it. I'm able to just play. And that's because my basal ganglia has helped me to learn those motor patterns that are necessary for me to be able to play in a more automatic way and a less intentional way. Another example of what the basal ganglia do is they help us with the accuracy of movements, particularly, very importantly, the amplitude and the velocity of the movements. So think about cursive handwriting. You know, when you go to write in cursive, it's very important that you sort of stay on the line, and that you don't, go outside and make really big letters, and some letters big and some letters small. So you have to be able to control the amplitude of those hand movements, for example, when you're writing in cursive. And you want to make sure that you're doing it at the appropriate speed so that hopefully it's more legible. So if you take this to something like speech and you think about the amplitude of the movements and the velocity of the movements, and you think about the articulators, and you think about the fact that somebody with Parkinson's disease typically has a hypokinesia, meaning reduced amplitude of movements, reduced velocity of movements, you start to get an appreciation for what might be happening as that individual is trying to communicate with you. The other thing that the basal ganglia do is they're very important in helping us learn movement patterns and the associated behaviors that go with those movement patterns. So talking while walking is a good example. Most of us never think twice about talking and walking. We're just walking along and we're talking. I'm sitting here talking and gesturing and moving a little bit in my chair, and I'm not having to split my attention at a conscious level between movement and speech. It just happens, walk and talk. Very similarly to something like driving. I would say to you, if you drive the same route every day to work and home, there's oftentimes you get home and you don't even remember how you got there. You just remember getting in your car on campus. Next thing you know, you're in your driveway and you never really thought about it. Well, the basal ganglia are largely responsible for that. They help you to engage in the behaviors and the movements that are more automatic and learned kind of behaviors. And they're based on the circumstances that you're in. So you might not be even aware of how you're driving until it starts raining, or until somebody honks a horn, or until you see something ahead, like a dog that might be, about to run out onto the road. And then you become more aware of it. But for the most part, the basal ganglia just kind of operate in the background, and we're just kind of cruising along and moving and learning and taking things that are truly intentional when you think about them and make them automatic, okay, until they no longer need to be automatic and they need to become intentional again. And then equally as important is the idea that we don't want to move when we don't want to move. We don't want movement that's going to intrude on our given plan for how we're trying to move. So we don't want a hyperkinesia. We don't want something like a Tourette syndrome or a Huntington's chorea or essential tremor or something like that. We want to be able to be steady in our movements and not have anything interfere with those movements and make that automatic movement become intentional because we're trying to hold back from moving too much. And so the basal ganglia are very important in sort of coordinating all of these things in terms of functions, all of which have correlates not only to general motor movement, but specific to speech movements and to speech itself, and swallowing movements for that matter. And the way this all is accomplished in the most basic sense is through a balance of neurotransmitters, right? Acetylcholine, dopamine, and GABA. And dopamine really is the key neurotransmitter that we want to think about because dopamine is very important in either the excitation or inhibition of the motor cortex. As you recall from your own learning, the motor cortex is very important for initiating movement and receiving information about how that movement is taking place through the sensory cortex. And so having that ability to initiate movement and keep the movement going is very important. And dopamine is very important in doing that. If you don't have enough dopamine, you end up with a hypokinesia, like in the case of Parkinson's disease or Parkinson plus syndromes. If you have an imbalance where there's too much dopamine relative to the other neurotransmitters, you end up with a hyperkinesia like Huntington's disease or Tourette's or essential tremor or tardive dyskinesia or hemibolismus or any of the other hyperkinesias. So it's very important that there be a balance between the acetylcholine, the dopamine, and the GABA. So here's a visual, because some people are more visual learners, and I found this really nice source here that's cited on what the normal voluntary pathways look like. So for all of us who don't have Parkinson's disease. So if you just look at the 1, 2, and the 3 sort of sequentially, what you see is that you have, at stage 1, you have, the dopaminergic neurons in the substantia nigra are activated, okay? And then that influences the striatum. And one of two things happens. You have, or both actually, you have an increase in the direct pathway excitation, and you have a decrease in the indirect pathway. And the direct pathway is really the pathway that's very important for movement, more so than the indirect pathway. And so when you go down to step 2, you see that increased direct pathway activation. You see a decrease in the indirect pathway activation, which ultimately acts on the thalamus, which is a relay station, a subcortical relay station, which then acts on the motor cortex, which then acts on either the cortical spinal tract, if we're talking about limb movement, or the cortical bulbar tract, if we're talking about speech movements. And ultimately, that pathway allows us to have voluntary, smooth, controlled movements. Again, operating all in the background under this normal voluntary motor pathway because we have the correct balance of neurotransmitters. And most importantly, we have sufficient dopamine in the basal ganglia to stimulate and excite movements that are necessary to get the result that we're looking for. So now when we talk about Parkinson's disease and we start thinking about what's different than in somebody with Parkinson's disease. Okay, so here's a very similar, same source, but similar diagram. So actually, if you start over on the left, you can see this is the midbrain of a patient with Parkinson's disease, where there's a lot of depigmentation, meaning there's not enough substantia nigra. Substantia nigra means black substance. And you don't see nearly as much of this black substance in the substantia nigra. Okay, so you don't have as much dopamine. And so what happens? Well, if you look over to the right and you look at, 1, 2, and 3 as I added to the image, one of the things that you'll see when you have a decrease in dopamine in the basal ganglia is a couple of things happen. First of all, if you just skip down to number 2, you have a reduced output, okay, from the substantia nigra through that whole loop to the cortex. So the cortex doesn't get stimulated to the same degree because there's not enough excitation coming to the motor cortex through the loops that go from the basal ganglia to the striatum to the cortex. And so the motor cortex is understimulated. So as a result of that understimulation of the cortex, ultimately, when that information travels through the central nervous system from the motor cortex to either ultimately the corticospinal tract for limb movement or the corticobulbar tract for speech movements, there are not enough movements. The dynamics are decreased. They are hypokinetic. And so what you end up with, if you look down at the bottom of the diagram, is you end up with, the bradykinesia, the rigidity, the postural instability, and so on. Resting tremor potentially. And so ultimately what's happening in our patients with Parkinson's disease is movements are not facilitated because the motor cortex is not ultimately stimulated to create a situation where muscles contract and structures move in a normal way. And again, the central basis for that is a decrease in dopamine in the substantia nigra, which is part of the basal ganglia. So I mentioned earlier the direct and the indirect pathways. Okay, so the direct pathway is excitatory, as I made reference to earlier. The indirect pathway is inhibitory. And so when you have a loss of dopaminergic cells in Parkinson's disease, you end up with, again, decreased excitatory input, increased inhibitory input. So you have both things happening. The motor cortex is not stimulated enough to move, and it's also inhibited from moving at the same time. And ultimately, you end up with the hypokinesia that I made reference to earlier. And so hypokinesia is generally described as a decrease in the amplitude, force, and speed of movements. So if you think about a Parkinson's patient who's coming into the room and walking down the hallway at the Parkinson's Voice Project, okay, and they're walking down the hall, and you look at the amplitude of their movements, their arm swing, their gait, their walking. You look at their facial expressions or lack thereof. You look at their posture, their kind of stooped posture, okay, and they're kind of shuffling along, and sometimes they freeze when they go across a threshold into another room, or they just freeze for no reason. Well, they basically have had reduced amplitude of movement. When you're listening to their speech and you're looking at their facial musculature and you're looking at their lip movement or their mouth opening, you see a decrease in the amplitude of the mouth opening. So for a normal patient, when you have them go pa, 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 you see a lot of amplitude of movement, a wide range of movement. And the normal person has normal force to that movement. So it sounds nice and sharp. Pa, 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 pa. Okay, and the speed, when you say, do that as fast as you can. Pa, 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 like that. Well, if you have hypokinesia from Parkinson's disease, your amplitude of movements is reduced. So you watch your Parkinson's patient when you're doing an oral mech exam, and you have them go pa, 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 and they do this. They go pa, 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 pa. They're barely moving their lips. They're barely opening their mouth. And as a result, they have less force. So when their lips are coming together, there's less force. And the sound wave that's generated from those lips coming together is a weaker sound wave. No different than if I take my hands wide apart like this and go, it's loud because I had a wide amplitude and a lot of force. That's the normal person. Take somebody with hypokinesia and they're going, they can't generate the force because they don't have the amplitude of the movements. And oftentimes the movements are slowed down. So when you can't produce forceful movement because you don't have the amplitude of movement, you end up with speech that sounds like it does when somebody has Parkinson's disease, right? They have a hypokinetic dysarthria. They have these other signs and symptoms. They have the tremor, the bradykinesia, the rigidity, they have postural instability, and there's apathy as well. And sometimes we see this in Parkinson's patients where they just seem to be apathetic. They're not responding to the fact that their speech is ineffective or that their speech has changed from what it was before. And that's part of, as a result of also having a decrease in dopamine, okay? Because the basal ganglia are also involved in motivation to move, initiation to move, and reward for movement reward. is also mediated by the levels of dopamine. So when you have not enough dopamine, you don't get the same reward for moving as you do when you have an appropriate amount of dopamine. And so sometimes the Parkinson's patients, they're just sitting there and they just don't seem aware that their speech is different. And it has to become a more conscious thing that you work on with them to help them become more self-aware of the fact that their speech is different and that they have these other signs and symptoms that they're exhibiting, because oftentimes they're not aware, particularly the further along in the disease process they are. So I just put this up just, for sake of quick discussion about what are some of the things that you would see in a Parkinson's patient relative to tremor, bradykinesia, rigidity, and postural instability. And you can see there's a number of things, but all of these things can account for why we hear the speech that we hear in somebody with Parkinson's disease, okay? So if there's an inability to control movement, the balance of movement from inhibition to excitation, and there's an imbalance, then all of a sudden a tremor can start to occur. And you'll hear tremor, particularly in the vowels, of somebody that has a hypokinetic dysarthria. Sometimes it's apparent in the connected speech, but it's usually more apparent in the vowel production when you have them do an isolated vowel, for example. Bradykinesia, again, think about this. You have a patient who has just slowed movements. Okay. They may be moving. You see your patients with Parkinson's disease who has kind of a shuffling gait, and they're kind of stooped over. And you're seeing movements, but they're very, very slow. They're not getting anywhere from point A to point B because they can't move their legs quick enough in order to propel them from point A to point B to point C in any kind of reasonable situation. Interestingly, when they're stimulated, for example, if they're really scared, they can sometimes move faster, which is always an interesting finding that the neurologists love to make note of. At other times, they're moving slower, but if they think a dog is chasing them, for example, they'll move faster. Or if they think there's a fire in the house, they'll pick up their speed. And I've had patients report this to me, and I've had caregivers report this to me as well, that under certain conditions, that bradykinesia can be mitigated by circumstances, environmental circumstances. And then, of course, you have the rigidity, and you'll see that rigidity sometimes in the limbs. You'll see it in the oral movements. And so, again, when you have structures that are rigid, meaning they're not pliable, they're not flexible, they're not easily movable, or they don't move smoothly, you again think about how that's going to affect speech when you're thinking about all of the articulators that are involved in producing speech and all the phonemes that we have to select and plan and program and execute. You need to be able to do that fluently. If the structures are rigid, then speech doesn't come out very easily. It sounds disfluent at times. It sounds like there's a struggle, even though it might be low volume and kind of flat. It doesn't have that fluidity to it that we oftentimes expect in patients, or not in patients, in normal speech. And then the postural instability, we oftentimes think about postural instability with Parkinson's patients with, the example of standing or sitting. What kind of posture are you in from a standing and sitting standpoint? But there's a lot of speech postures that we assume. So for example, if I said to you right now, where's your tongue in your mouth? You're probably thinking, I don't know, I never thought about that before. But if you're not talking, your tongue is in a particular posture in your mouth. Probably not up against the roof of your mouth. It's probably not on the floor of your mouth. It's probably not resting between your front teeth. It's probably not resting between your back teeth. It's sort of in that central position, right? You think about making a schwa sound, kind of that neutral sound in the vowel quadrilateral where your tongue is kind of in the middle of your mouth. And so I say to you, why? Why is that the resting position? Well, that's a posture that your tongue is in because the basal ganglia and the cerebellum are putting your tongue in that position because that's the most efficient position for your tongue to be in for when it comes time for you to speak. You can hit the targets that you need to hit within that vowel quadrilateral in order to produce the sounds that you need to make. It wouldn't be very efficient if your tongue was sitting on the floor of your mouth, for example, or up against the roof of your mouth. It would take more effort to get from point A to point B than if it was just sitting in this neutral position. Well, the same thing is true with the mandible. If I say to you, where's your jaw right now? Is your mouth open or closed? You'd probably say, Some of you would say open, some of you would say closed, depending on whether you're a mouth breather or not. If I say to you, how open is your mouth? You have to think about it. Most of us, when we're not talking, our mouth goes into a posture, a resting posture. That's not by accident. Okay, it rests where it rests because for you, that's the most efficient place for it to be as a starting point for when it needs to move to produce speech or to swallow. And then it goes back into that resting posture afterwards so that it's ready to go the next time. Well, that isn't by chance. That's because the basal ganglia and the cerebellum are putting it in that position, putting these structures into those positions. Same thing with your vocal folds. So postural instability doesn't just refer to what we think of typically as posture, like a physical therapist would, evaluate somebody for posture. It's really, for us, we're thinking about, in addition to those things, we're thinking about oral postures, okay, speech postures. And when you do an oral mech exam with somebody with Parkinson's disease, you need to look for that as well. So all of this ultimately leads to somebody having a hypokinetic dysarthria, right? And the neurologic underpinning for that, or the locus, is a lack of basal ganglia control. Ultimately, the primary deficit is rigidity and decreased range of movement of the articulators. Of course, you probably all know from the work of Darley, Aronson, and Brown, particularly if you're of my generation, there are some primary oral non-speech features and some secondary features that I've listed here. And these are typical things that you will see in a person with Parkinson's disease: a masked face, you'll see some tremor in the jaw, the lips, sometimes in the tongue. And again, you'll see this reduced range of motion for the articulators. You may see head tremor. Patients may experience dysphagia, and oftentimes they experience drooling as a complaint. They also have very clearly speech issues, primarily, as Darley, Aronson, and Brown would describe them, as prosodic insufficiency. The issues that are listed under the speech characteristics there, ultimately, the best cluster that one could use to describe this is prosodic insufficiency. Things like mono-pitch, mono-loudness, right? Reduced stress, syllable stress, short phrases, variable rate, short rushes of speech. And it's interesting, this category of speech rate in persons with Parkinson's disease. It's very interesting because, when I was first taught about speech rate in persons with Parkinson's disease, in 1985 or whatever, the focus really was on how fast are the articulators moving. In other words, the articulators are moving really fast, and that's why the rate of speech is fast. Over the years, we've come to find out through research that it's not so much that the articulators are moving fast as the primary reason that speech rate has changed. It's the fact that pauses are different in somebody with Parkinson's disease. If you shorten the pause length between words, you're ultimately going to get more words in per minute than if you don't pause, right? So if you're just talking along and you take a pause, and then you keep talking and you take a pause and there's a really long pause or an abnormally long pause, you're not going to get as many words in per minute. What happens in patients with Parkinson's disease is they oftentimes don't pause, or they don't pause long enough, or they don't pause to the same extent or the same duration that we do, because they're not aware of that. So they'll do things like, "He wished to know about my grandfather well. He's nearly 93 years old. He wears an old black frock coat, usually several buttons missing. A long beard clings to his chin, giving those who observe him a pronounced feeling of the utmost respect." They barely took a breath. That's part of the reason why they're getting so many words in per minute. So a lot of what I've done when I've worked with Parkinson's patients is to cue them to take a breath more often. Not just take a deeper breath at the beginning, but cue them to take a breath more often, which in and of itself slows them down. It's an indirect way of slowing somebody down, because to tell somebody with Parkinson's disease to articulate slower, say their words slower, that's a very abstract concept. That's a very hard thing to do, but you can slow them down, if that's your goal, by having them just take a breath more often, pause a little bit longer. And then ultimately at the end of that 1 minute period, they've gotten fewer words in. And it gives the listener the opportunity to track what they're listening to, perceptually, auditorily, to track where the speech is going and not feel overwhelmed as the listener by all the speech that's coming at them, not only more rapidly than they're used to hearing, but less dynamically than they're used to hearing. And it makes a real perceptual challenge for the listener in communicating with somebody with Parkinson's disease relative to this hypokinetic dysarthria. Likewise, I would be remiss if I didn't talk briefly about dysphagia in persons with Parkinson's disease, because many of the same things that I've talked about relative to speech postures and movement for speech and so on and so forth is also relevant to speech postures or oral postures for dysphagia and intraoral postures for swallowing and movements for swallowing. And persons with Parkinson's disease, as you well know, can have and oftentimes do have dysphagia, particularly towards the end stage. And it's very difficult for patients to, get food into the mouth, to process the food at the oral stage of swallowing and the oral transport stage, and even transporting the food through the pharyngeal stage to be able to swallow the food safely because they have these reduced movements. If you think about something like trying to move peanut butter from the front of your mouth to your back of your mouth, that's hard enough for any of us to do, or to take honey off of a spoon and prepare that bolus is hard enough. But if you have reduced range of motion and you perhaps have some weakened muscles and your muscles are moving slow, that becomes even more of a challenge. And so oftentimes patients with Parkinson's disease will pocket food. Again, they have the drooling that I talked about earlier because they can't contain the food within the oral cavity. They have difficulty transporting the food when it gets to the back of the mouth and initiating that swallow response and transporting the food muscularly through the pharyngeal stage and so forth. So dysphagia is a major, major consideration. And, if you work long enough with Parkinson's patients, you come to realize that generally at the end of life, patients are dying from aspiration pneumonia, ultimately. And they also develop a dementia, unfortunately. So it's very prevalent. Patients will report it. It can be objectively identified. I put a source here for you from 2012. In this particular study, 82% of patients had with Parkinson's disease had dysphagia. And again, it's somewhat commonly reported by patients and their caregivers. And of course, we know all the complications, right? I would say loss of quality of life is chief among them. When you can't eat and swallow, swallowing or eating is such a social event. So now you have a person with Parkinson's disease who already has a decreased quality of life because they can't communicate effectively. Now they can't eat as effectively. They can't eat safely. And so you take two things that are central to us being social beings, talking and sitting around and eating. And both of those things are now affected. And so quality of life, as you know, is decreased in persons with Parkinson's disease if these things are not addressed. And then more seriously, you have poor medicine intake, malnutrition, dehydration, and you have the depression as well that comes from the loss of quality of life as well. So I saw a lot of Parkinson's patients in the nursing homes, and they were isolated from the other patients in the nursing home. They were isolated in terms of social activities. They were isolated in terms of where they sat in the dining room, and all of these things, cumulatively created a very difficult situation for that patient in terms of their quality of life. And those things had to be addressed so that the patient wasn't excluded, but they could be as inclusive as possible given the abilities that they had. And of course, the aspiration pneumonia ultimately is the thing that usually causes death in most patients with Parkinson's disease. So we have to monitor these patients and get in early, right? Think about the situation of where is that patient in that environment? What kind of environmental manipulations do we have? Can we change where they sit? Can we change the loudness in the room? Can we put them in a quieter part of the room? Those kinds of things. Can we have them eat more frequently so that it's not as fatiguing for them or taxing for them to be able to eat, yet they still meet their nutritional needs and so on and so forth. So getting involved early and then monitoring throughout from a dysphagia standpoint is very critical to not only the quality of life, but the ultimate health outcomes that that particular patient has. So with all of that in mind, let's think about specifically what's happening in terms of speaking with intent, okay? So one of the ways I like to think about this is I wanted to start with this quote by Charcot, the great neurologist. When a patient calls on you, he is under no obligation to have a simple disease just to please you. He has every right to have a disease presenting as an extremely complex case. And while understanding Parkinson's disease may very well be a somewhat straightforward process, it is by no means a straightforward process to treat somebody with Parkinson's disease. It's a complex disease. It's a disease that over time creates different signs and symptoms in an individual patient. There's variability from one patient to the next to the next. And that requires us to have an understanding not only of the disease itself and the underpinnings of that disease, but the progression of that disease and how we intervene at various stages along the way. And our goal, of course, is to try to get these patients to do what is automatic for us to become more automatic for them. And when we want to do things that are more intentional, we want also to be able to teach our patients to be able to make their speech in particular less automatic, given where it's at now with the hypokinetic dysarthria, and make it more intentional and less dysarthric. So we're taking automatic function, which is speech, and let's say in this case, it's their hypokinetic dysarthric speech, now is what's their automatic speech. We're introducing the concept of speaking with intent, and we're now making that speech more intentional and therefore less dysarthric. In other words, more natural, more understandable, more intelligible, and easier to produce. So how do we do that, right? One of the ways that we do that is we scale up the mental and physical effort that's required for patients to produce speech. And this is oftentimes an obstacle early on, because the patients, again, if you think back to what I said earlier, the patients aren't necessarily as aware that they're not scaling up, that they need to scale up. And they'll oftentimes tell you when you're working with them to try to get them to scale up effort, they'll perceive that scaling up as too much effort. They'll say to you, I'm not going to, that sounds like you're yelling. I don't want to yell. And you're saying to them, I'm not telling you to yell, right? And so you have this education process that's going on to make sure that they realize that their scaling up of effort is essentially taking them to the baseline of where they were before they had the disease. It's not like telling you to scale up and all of a sudden you become dramatically louder from normal. Scaling up for a patient with Parkinson's disease, the concept is to scale them up to as close to quote unquote normal as one can get it. And so you have to think about how you're going to do that. Well, you do that by thinking about it ahead of time. You do that by the interventions that the Parkinson's Voice Project Speak Out, for example, is based upon. And it also requires very much an intentional awareness of how one is moving, how one is producing speech. It's not just beforehand you discuss it. It's when they're in the act of speaking that they're actively monitoring whether or not their speech truly is meeting the goals that it needs to meet. And after they've spoken, focusing on the listener and understanding whether or not they met those communicative goals that they set or those objectives that they set. So it's not just at the beginning, it's at the beginning from an awareness standpoint, it's throughout the speaking act that it's very important, and it's after the fact that they can self-reflect on whether or not they spoke with intent. So scaling up is one thing, scaling up and staying scaled, and then recognizing whether one did scale up are all very important considerations when you're working with somebody with Parkinson's disease. And each of these is addressed through the Speak Out approach. So here's some of the verbal cues, right? Say it with intent, say it purposely, say it like you're in charge. These are all cognitive approaches that one can take to get the patient to become more consciously aware. And I oftentimes say to patients, I really want you to think about your speech. Excuse me. I know you don't want to, and I know it seems unnatural, but you need to think about it as we're going through this process so that eventually you don't have to think about it, right? And that all of a sudden it becomes what seems very intentional for you now will become more automatic for you over the course of time. And you saw the presentation, from Dr. Berman about the work that she's doing and her colleagues, and the research shows that that in fact is what happens. The intentional speech becomes a much more suitable and effective automatic speech for that given patient. Okay. And this idea of automatic versus intentional, are vocabulary words that I use. I mean, I say, my speech is automatic. I'm not thinking about it unless I need to speak louder. And I say this to my patients. Your speech is down here like this. You're not thinking about it either. because this is now your new automatic. Well, you need to speak up. You need to say it like you mean it, like you're the boss, like you're giving somebody directions, like you're the field commander, or you're whatever your position is. You're in an authoritative position. It's cueing them to the idea that they need to be more intentional. And of course, speak out is the greatest way to describe that. I mean, it just captures, exactly what we're trying to get these patients to do in terms of intentionality. Is just speak out. Don't yell, don't scream, just say it with intent. That's the essence, it's saying it with intent. And by doing that, cueing patients ahead of time, it actually increases the motor output from the motor cortex, irrespective of the dopamine levels. So the handout that you have, I've included these particular slides because motivational factors have been shown to influence motor behavior, not just speech motor behavior, but limb motor behavior, for example. And I talked earlier about the idea that if a patient with Parkinson's disease, needs to get out of the way of a car, or they think a dog's going to attack them, or they think the house is on fire, and they have this increased arousal, they can move faster. And that's not because, they got a shot of dopamine, right? Because of the cognitive emotional link from the limbic system to the cortex, to the basal ganglia, and all of that pathway. The substantia nigra is very important, very important. All this associative information that comes in about how did we move? Am I moving? How did I move? Was that movement successful? All the associative things that go with movement are also very important. And that when a patient has more awareness of those things, cognitively aware of those things, it influences their motor output. It increases their motor output, much like if they had an increase in dopamine would increase their motor output. And there's more excitation and everything has more dynamics to it from a neurophysiological standpoint. Again, here's another example. There's research that has shown that when one is more intentional, that information actually gets interpreted by the brain prior to the movement, So when they've done MRIs and they've done other studies, they can show that the motor cortex lights up in a different way, particularly the primary motor cortex, when somebody is thinking about movement, whether or not they've actually moved. Just the thought of moving, the intentionality of movement, that awareness that they need to move actually preloads the movement itself. And that's also very interesting. I've got friends here that have done research in this area that are physical therapists, and they've shown some really good results with Parkinson's patients that have had nothing to do with changing their medication, just simply making them aware, making them intentional, and seeing that these limb movements improve. And although this hasn't been studied specifically to speech, if you think of the speech subsystem as a subset of the general motor the motor subsystem, and reflective of the motor system as in large, I think it makes sense to think that having that intentionality would also help to create more purposeful, meaningful, intentional speech movements. When you think about reward, go back to what I said earlier about Parkinson's disease and dopamine. And dopamine is very important in the reward system. When we do things that are pleasurable to us, it's because there's an increase in dopamine. That's part of the reward system. Well, if you think about having a patient who is able to get a lot of positive reinforcement for what they do, and of course the Speak Out program builds in a lot of reinforcement, a lot of positive reinforcement, so that patients continue to stay motivated to make their speech more intentional. That idea of positive reinforcement is rewarding. And again, when there's an increase in reward, there's generally speaking an increase in intentionality of thought and intentionality of movement. And so rewards are very important from a neurophysiological standpoint, as well as from a psychological standpoint, in keeping patients aware of their need to turn their not effective automatic speech into much more effective intentional speech. Oh, sorry, let me back that one up. So I started with Dr. Boone. He was a great mentor to me. He passed away a couple of years ago. I owe everything in my career to Dr. Boone. I was a undergraduate student that was really lost, substandard undergraduate student by today's standards. And Dr. Boone came into my life and really changed everything for me, motivated me, guided me, gave me the opportunity to go to graduate school for my master's degree, was a great mentor to me throughout that program, encouraged me to go on and get my doctorate, continued to mentor me after that, gave me the opportunity to co-author his book. So there's literally not a day in my life that I don't go by that I don't thank God that he came into my life. He was a very forward-thinking individual. He had this idea of intent many, many, many years ago, decades ago, and he put it into practice. And it's very rewarding to me. And I know it was very rewarding to him when I spent time with him at the PVP and in all the conversations I had with him in subsequent years. He felt just very validated, not from an ego standpoint, but it was very validating to him that something was being done that was making a difference in the lives of other people. And that's what he was all about. He was about making other people's lives better, whether they be students, colleagues, or patients. And he was beloved for that. So I feel very blessed that I had the opportunity that he was in my life. And I'm particularly blessed that I had the opportunity to get involved with Samantha and her colleagues through Dr. Boone. And it's been my total joy to be able to talk to you today. And I look forward now to this pandemic coming to an end and coming out to PVP next year or whenever you'll have me back. So if you have any questions, I'm happy to answer them.
Thank you, Dr. Schrake. There is one question that came in. It says, is hypokinesia with decreased amplitude of movement responsible for difficulties slowing down, such as when rushing to an appointment because they are late and not being able to stop themselves and running into walls or people because they cannot get those signals firing quick enough to change direction? What would
Yes.
be that for festination?
Okay. So in that festinating gait, for example, part of that issue goes back to the earlier slide where I talked about that balance between excitation and inhibition. When you have the appropriate balance of neurotransmitters, you have the appropriate amount of excitation and you have the appropriate amount of inhibition. When there's an imbalance in those neurotransmitters, not only do you not have enough excitation, which is the hypokinesia, but you also can't inhibit some of the movements, the unwanted movements. And the festinating gait, for example, is a good example of an unwanted movement. You don't want to keep going, but yet you don't have the neurochemical control via the basal ganglia to stop yourself from moving. So you end up with two situations. You either end up with a shuffling where they have a freezing on one end, or they have a festination on the other end.
Okay, we have another question. Thank you, Dr. Schrake. It says, do you find more that patients with Parkinson's have voice tremors in vowel production, or is it more often glottal insufficiency and reduced breath support causing poor quality, intensity, fluidity, and phonation?
Wow, I would have thought maybe one of my graduate students from this morning fed you that question, because that very question came up this morning. That's a really good question. So the way that I look at tremor in Parkinson's disease or any dysarthric patient is you can hear it oftentimes in connected speech, but the best place to hear it is in vowels. Because in vowels, you've just got the context of the vowel, and you're going to really hear that tremor, which is essentially an irregularity in vocal cord vibration. And you'll hear it in vowels. You'll hear it particularly in the E vowel. Patients with movement disorders, when I was in the movement disorders clinic, we would have them sustain an E vowel, E. And when there was tremor, you would hear it, E. Now, the way you differentiate that specific to your question from insufficiency, glottal insufficiency or respiratory insufficiency, is in tremor, it's very rhythmical. You can lock into that. The amplitude of the tremor is rhythmical. The frequency of the tremor is you can lock into that. It's very regular. It's very easy to track that. And it's usually consistent. When you have insufficiency, for example, respiratory insufficiency, and you have these, this glottal stopping, if you will, and you have like that, that's very different than the kind of tremor that we hear traditionally in a patient with Parkinson's disease. Now, to rule that out, Is it one or the other, or sometimes both? I always start all my evaluations of patients with Parkinson's disease looking at respiration first. And when I can rule out that respiration is not the cause, and then I isolate the phonatory system and listen for the tremor, that helps me figure out, relatively speaking, where is the problem lie? And if it lies in both systems, what is the relative contribution of each? But yes, that's a very good question. You want to start very carefully examining the respiratory system.
Thank you. And I do want to make sure that we clarify, speech is never going to be automatic for people with Parkinson's, but the more they practice, the more they use intent, it may not require as much intent.
That's an excellent point. That's what I meant. But
Okay,
yes,
I wanted to make sure that everybody
Yes.
realizes that it's never going to be automatic, which is what makes the daily home practice and the loud crowd essential. It'll get easier, but
Right.
it's never going to be automatic like it is for you or me.
Right. Exactly right.
Okay, here's another question. How do you help with the apathy issues in speech therapy due to the emotional loop feedback aspect of the basal ganglia when clients are not aware of this in themselves?
That's a very difficult question because there's only so much motivation and awareness that you can create in a patient and help a patient to become more aware of. And in many cases, it's beyond what we're able to do from a behavioral counseling intervention point of view. What I've noticed, though, is that apathy definitely decreases when patients are on cycle for their medication, when they're in the on state of their medication, if they're on levodopa, for example. And so when I was in the movement disorders clinic and this issue of apathy would come up, sometimes there needed to be just a slight adjustment to the medication to really make the difference in making them less apathetic. So it was really more pharmacological intervention once the behavioral counseling intervention had sort of maximized the patient's ability.
Yes, yes. And definitely loud crowd, becoming more aware and that they have hope that they can get better. That has a lot to do with it. And we encourage our loud crowd members to definitely set a routine, which is one reason when the pandemic started, we have been doing the online speech exercises. If you notice, we don't just do them, every Monday. We do them Monday through Friday because they need that daily treatment. There is another question, and it says, what is the expectation for decreasing palilalia? And I want to just mention that I have a number of patients with this, and they have to practice every day, probably a couple times a day at least, to develop, good functional communication. But what do you think, Dr. Shrake?
I agree with you. A lot of times the patients are less aware of the fact that they're polylalic than the people who they're in the environment with, who they're speaking to. And so making them aware, teaching them how to track that. Sometimes you can have patients who you can teach them to be, that the increased awareness makes them anticipate that may happen. And just knowing that it may happen or having an awareness that they may go into that polylalic mode can sometimes diminish it. So yes, I agree with you, Samantha. You need to really identify that early and just make that a regular part of their approach to managing their speech.
And another reason that we need to get patients to know about this and be evaluated early on. There was another question about neurogenic stutter. And again, the Speak Out protocol works in a hierarchy, and we can't expect, if they can't do the counting, that they're going to be able to carry on a conversation. So we've got to take one step at a time. And I also believe that using intent and stretching out those vowels, it really, really helps.
I agree.
Yeah. And then the only other comment was about how do you reduce hoarseness, glottal fry, improve vocal quality in someone with PD? And I would say speak with intent. What do you think?
No, absolutely. I mean, and that's the issue. I would say it's the same thing with somebody who doesn't have Parkinson's disease. Oftentimes, in the voice clinic, when I see quote unquote voice patients, a lot of their issues that you just described are because they're not breathing properly, right? They're not valving properly. They're not coordinating that breath flow with the phonation. And Parkinson's disease patients are no different. I mean, I'm a really strong proponent of assessing respiration, not just for the sake of respiration, but respiration for speech. You know, what's their speech breathing like versus their breathing for life? You know, what's that relationship between the inhalation and the exhalation times and the timing of the voice onset and the cessation of the voice and all of that efficiency of getting that air flow through the larynx to help generate the strongest, you know, voice signal that you have that can then be shaped into the most intelligible speech signal. So I say always go back to, even if it appears to be largely laryngeal that you're focusing on from a perceptual standpoint, is to step back and remember that the larynx isn't going to operate without the respiratory system. You're not going to have a voice.
Yeah, definitely. The main issue with Parkinson's is the incoordination of the breath support for speech.
Right, because of the reduced dynamics of the movements.
And so many patients who do have that glottal fry, what happens is they start backing off. So they start taking smaller breaths because before Parkinson's, if their voice was raspy, you know, if it was laryngitis, they might back off, and they tend to back off when they hear that. But when they speak out, use better breath support, the vocal quality improves.
Exactly. And remember too, for the most part, we're talking about patients who are elderly, right? So you have the normal aging process that's going to affect respiration and phonation and resonance and articulation to begin with, just by virtue of normal aging. And then now you're superimposing a disease on that. So you're dealing with two things. You're dealing with what would be normal age-related changes and a disease process. And so you have to calibrate your expectations around those two things.
And I think speaking with intent would help the normal aging voice also.
Absolutely. Absolutely. I use it all the time.
And a lot of teenagers. Dr. Shrink, thank you so much.
You're welcome.
Really appreciate it. You're getting rave reviews in the chat. So
My pleasure.
thank you so much. We are going to start back up. We're going to take a little break, and then Gwen Nolan will be here at 11:30 Central Time. So we've got about 12-minute break. Thank you so much, Richard.
You're welcome.
Hi, everybody. I am so excited to be here. My name is Gwen Nolan, and I am the clinical outreach coordinator here. So if you haven't met me, you will. And I'm the person generally responding to the grants emails, although it does take a village. Julie will be starting the PowerPoint and we can get going. We don't have a lot of time. And there's lots of ground to cover. So today I'm going to be talking about intentional teletherapy and adapting Speak Out for online service delivery. It takes a village to put things together here, including this webinar, and everybody needs a tribe. This is my tribe, a wonderful group of people who helped us put together this whole webinar. So a thanks goes out to everyone. We couldn't do this without you. Disclosures. I'm so lucky. I receive a salary as an employee of Parkinson's Voice Project. I get paid to do what I love. How wonderful is that? No non-financial disclosures. So why do teletherapy? I was involved with teletherapy before COVID ever hit, and I saw the advantages. But the pandemic really did teach our profession quite a few lessons. Many clinics were shut down. Many clinics had to make the decision to shut down or move to online. And here at Parkinson Voice Project, we moved online and we found that Speak Out was really easy to adapt to teletherapy. Many of our patients are tech savvy, and they were willing to give online therapy a chance, which is great. Probably one of the biggest advantages was our ability to reach people. If they had an internet connection and a smartphone, we can reach them through teletherapy. People who have transportation issues, people who for health reasons are homebound, or people who live too far away from a clinic to make travel possible can now access services. And our patients, we found, really liked teletherapy, and they're meeting their goals in as few as 8 sessions. So it's been amazing. The other piece was in response to not being able to bring loud crowd members in, Samantha started doing online speech exercises, and they have been amazing. They keep our patients engaged and they attract new patients. So you might be asking yourself, well, which is better? What do I think is better, teletherapy or in clinic? The great Mike Tomlin, head coach of my beloved Pittsburgh Steelers, would say, the standard is the standard. This is true for teletherapy and in clinic. The standard is the standard. Asha agrees. The use of telepractice must be equivalent to the quality of in-person services and consistent with our code of ethics, scope of practice, state and federal law, licensure, HIPAA, and ASHA policy. So it has to be at least equivalent, at least as good. So if you're new to teletherapy, you might wonder which online platform. This was a much harder decision a bit over a year ago than it is now. There are so many platforms to choose from. Here we use Zoom and their HIPAA compliant platform. I would say whatever platform you choose, just make sure that it's HIPAA compliant and user friendly for your patients. The technical aspects may differ a little bit from platform to platform, but know that the teletherapy procedures, the stimuli that you use, the treatment forms, they're going to be the same. So whichever platform you use, just make sure it's simple for your patients. You're able to give them simple instructions. You never want to send them more information than they need. And know that stuff happens. It doesn't matter what platform you're on. There will be technical glitches and you can work through them. Just make sure you've got the patient number handy. Okay, so you're trying to decide, Is your patient appropriate for teletherapy? Well, they need to have access to a computer with internet, a webcam, a microphone, and speakers. But if they don't, are they able to participate using a tablet or a smartphone? If they don't have any of those things, there's not going to be a way to connect, so they wouldn't be appropriate. But if they do have at least one device, can they click a link to participate, or do they have someone that can help them? Are the directions, can they follow simple directions, or do they have help? If they don't, they probably won't be able to participate in teletherapy. We find that the vast majority of people are able to do this or have someone that can help them. So in clinic versus teletherapy, yeah, there are differences. During face-to-face evaluation and therapy, we can use an SPL meter to measure loudness, and we can control the variables. They're right with us, so we can make sure that the mouth to mic distance is consistent. We know that the meter is calibrated and accurate. We also measure maximum phonation time using an eye, and we can use a timer or a stopwatch. And we use maximum phonation time in dB to objectively measure improvement and success. During teletherapy evaluation and therapy, collecting SPL data reliably is hampered by a number of factors. It can be done, but the cost of equipment, the program complexity, the potential cognitive or technical limitations on our patients' end, and the inability to really control their environment kind of make it difficult. But we can still measure adoration, and we can use additional tools, both objective and subjective, to measure improvement and success. So I challenge you to think about intent in a new way. If you took the online course, you know that intent is measured in terms of loudness and adoration, but hopefully you also realized in watching the videos, and if you're working with patients, it's something you can see and you can hear. And teletherapy challenged us to really think about intent, what it looks like, what it sounds like. Understand that it's more than a number on an SPL meter. And the importance too of being really intentional clinicians. So let's talk about what intentional speech sounds like. So perceptually, what do you hear? It's deliberate and purposeful, right? It's forward-focused resonance. The speech rate is consistent. The breathing is controlled. It's loud enough to be heard given the communication situation. It's intelligible for that patient's linguistic level. And the voice is projected forward. It's strong and it's clear with no end of utterance fading. What does it look like? Well, there's visible effort. You can see people putting forth effort. Right now, I'm being very intentional in this presentation. In our patients, we see increased oral excursion, greater articulatory movements, varied facial expressions, improved posture, deeper breaths. We can see these things. So Julie's going to run a video for us, no sound. So I want you to take a look at this. Watch the difference between the pre and post, because you will see what intent looks like. Okay, so it was really interesting. A lot of people wanted to hear the sound. You'll get to listen to them in a minute, but I want you to think about what you saw. There was a visible difference in these patients pre and post, and you could see that. And the takeaway was that's what I wanted you to understand, that without even hearing them, you can see what intent looked like.
Gwen, would it be
Yes.
possible? So many people thought there was something wrong with the sound. Can we show it one more time without the sound? So
I
that
think so,
people-
yeah. Julie,
I want
go
everybody,
back.
yeah, I want everybody to, yeah, pay attention to what intent looks like.
Okay, so hopefully you noticed all of the things that we talked about, the increased facial expression, the better posture. You could actually see how deliberate they were in those post videos. All right, let's go to the next slide. So now I want you to listen to them, because you'll not only see the change, but you'll hear it.
There are times I make many efforts, many attempts to get somebody else to just give up on me. Now it's much stronger, much clearer, the words are more concise. I sound like a human being.
Count from 1 to 15.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
My wife has noticed it more than I, but apparently I've lost a lot of oomph in my voice. It's me talking, and it's me, only as part of this process did I learn that I had relinquished control of my voice and relinquished a significant part of my life, which is being sociable and social, and now I think I'm back in charge, or I'm on my way to being back in charge.
It's much softer and more difficult to speak. I speak louder, clearer, and with intent.
So think about what you heard. It is magical to bear witness to people using intent the improvement is absolutely amazing. But consider that you actually watched that. So these weren't people who were face to face. So think about that from a teletherapy perspective. By the way, many thanks to our patients. We are so grateful to them for allowing us to share these videos because they're just so powerful. Okay. So based on what you saw and heard, think about the objective measures you could use to determine improvement in your patients and subjective measures too. And think about how intentional you are during your sessions. Teletherapy, we always want to be intentional clinicians, but teletherapy does require something extra because we aren't in person. Next. So you need to be deliberate in your speech and your actions. You know, whether you see people in clinic or online or both, you really need to model the intent that you want to see and hear from your patients. You want to focus not just on the data that you're collecting, but globally how your patients sound and look. Look at your camera. This is a huge, huge challenge. And I really struggled with this when I first started to do teletherapy. It can be very difficult to not want to do self-checks. It's really better. You need to be looking into the camera because you're talking to your patients when you're instructing and providing feedback. If I look down here, I can see the chat, but I'm not looking at you. And it really means something to have that eye contact. And unfortunately, the eye contact is with the camera, but just it's a learning curve that you'll get used to. I recommend before you get started, the intentional clinician pays attention to their background so that, you know, if you see it, your patients will see it, and it can be incredibly distracting. It might be people walking behind you. You might have an open bathroom door. Even if nobody's using the bathroom, do you really want that as your background? Probably not. So check the background for noise and distractions and dress for success. There's still a professional standard. And you know, if you have to get up and go get something during treatment, you really don't want them to see you wearing sweatpants. All right. So what's the takeaway? So patient success with Speak Out Teletherapy means you understand what intent looks and sounds like in your patients. You know ways to measure it subjectively and objectively, and you don't just model and cue for intent. You are very deliberate when you're instructing your patients during teletherapy sessions. So measuring intent during teletherapy, the possibilities are endless. So I'm going to start out with patient voice and communication questionnaires. There are many of these surveys. Varying degrees of validity, you can use them pre and post treatment to get patient impressions. These are a few that are available. So the VHI, CPIB, the voice related quality of life. There are also swallow questionnaires out there that can provide information that help you to know whether your patient's also experiencing swallowing difficulty. The 810 is a very popular one, MD Anderson dysphagia inventory. So there are a number of those out there also. We use the communicative participation item bank short when we do surveys and the EAT-10. So the CPIB short and EAT-10. Let's take a look. So this is, I'm not going to dwell a lot on these. These are available online. I've given you references for looking them up on the slides. But I wanted you to get a sense of what this looked like. It's very simple, you know, both from a cognitive complexity standpoint. And it just kind of asked, does your condition interfere with talking to people you know, people you don't know, communicating when you're out in the community? And it gives people kind of a rubric, not at all, a little, quite a bit. Remember, there are sensory issues though. So, you want to take these with a grain of salt. Sometimes they're actually worse after treatment because people are more aware. This is an example of what the EAT 10 looks like. There's also a reference there. I like the EAT 10. It's a great screen, and it's really, really great for kind of getting a sense of whether you need to dig a little deeper. So next slide. This is information on scoring these questionnaires. Very low bar for the EAT 10. 3 or above may indicate the presence of a swallowing disorder. So you really need to make sure you ask questions, review history, use your clinical judgment to determine whether you need to investigate further. Next slide. This is the CPIB short scoring table. Again, the reference is listed there. Next slide. You can also use subjective measures. One that we use here is a rating scale. These really scare people, and we're all, when you think about it, speech language pathologists are scientists. Every patient is a single subject design, right? And we like objective measures. But I want you to know that subjective measures aren't the worst thing ever, that they can be used with patients to help focus what you want your treatment to look like, where your patient's at baseline, where they are at end line. So they're good to use in combination with objective measures. You can subjectively rate a lot of things: loudness, intonation, vocal quality, articulation, and more. Here we use a 7-point scale when we evaluate and when we discharge. So we're looking at it twice, 2 points in time. The first time that we see a patient, and then at the discharge session. And we rank it from profound to within functional limits. So there's a pretty broad range. We look at vocal intensity, articulation, intonation, vocal quality, breath support, and then fluency and rate of speech. You can also subjectively rate the amount of cueing that you provide for your patients to use. And there's a broad range from, somebody who can fully independently use intent to someone who requires one-to-one cueing. You want to have benchmarks for each level. When I worked with students, I had clear benchmark levels for them so that they understood this is what a maximal cue looks like. This is what standby looks like, but you want to have benchmarks for that. So there are objective measures that you can use doing teletherapy, and acoustic analysis is one of them. You can measure vocal intensity, pitch range, and all of that using Pratt. The article that is below does a great job of explaining how to do that. It gives you objective data, but they point out in the article that it is very time consuming because you have to convert the audio. Then it has to go into Pratt to be analyzed, and it takes time. So it may be hard for many clinicians to complete this during typical evaluation and treatment. I spent almost 8 years in a university before coming here, but throughout the course of my career, I was a field clinician. I worked in hospitals, inpatient rehab, skilled nursing, home health, outpatient clinics. And I'm very aware of the productivity demands that you all are under. And you also have payer source requirements that we don't have as a nonprofit clinic. So you have a limited amount of time, right? I can remember someone once saying to me some years ago, well, you can do an eval in 15 minutes. No, I can't. I can't even write it up in 15 minutes, but that's the kind of pressure that I know you're under. So imagine having to spend an hour doing this, but I want you to know it can be done. The reference that I provided you will provide step-by-step instructions and information, norms for objective and perceptual measures. And that reference, incidentally, it's a tutorial for figuring out perceptual and objective measures for motor speech during teletherapy. So we can also measure maximum phonation time. Norms for sustained vowels are variable by age. We shoot for a 10-second ah. Some patients will need to work up to it. You can measure it with a stopwatch or timer. We do look at it at the very beginning of therapy, and we look at it throughout. If you're using Zoom, my helpful tip is make sure you turn original sound on so that you can hear the patient for the entire duration of the ah. Zoom and most other platforms have made great strides in working with people who do healthcare so that when we're working with a voice patient, they're not cutting people off after a certain period of time. Next slide. We can also look at syllables per breath and utterance. 13.2 syllables per utterance, got a reference for you on that. So we can measure how many syllables per utterance. You can measure speech rate. Here are some norms for that. We need to be careful about this in this population because there are differences related to the pause times and comparing people with Parkinson's to what would be normal. You just want to be careful about how you do that. But I wanted you to have these norms. Intelligibility. This is something we can measure. And adults, a typical adult should be nearly 100% intelligible at all levels. So look at where the breakdown is in your patient. You can write goals for that. So teletherapy forms, Speak Out providers, you can log into your account on Parkinson Voice Project's website and just click on clinical resources to find forms. They are all editable. This is what the website clinical resources look like. You're probably all really familiar with this, right? I know you spend all your spare time looking through the clinical resources, but these are really important. These are tools. Remember what I said about a tribe. We're your tribe as it relates to Speak Out and Loud Crowd. And the website has a ton of things that can help you. So this is what clinical resources looks like when you click that button. And if you click the treatment form button, you will see a pink box that says teletherapy forms. You're not going to see as many forms in teletherapy as you do on the regular one. Fear not. Some of the forms that we have are adapted for both in-clinic and teletherapy. So if it's not in here, it doesn't mean we don't have it. It just means, I can get the refresher from the forms link. So teletherapy evaluation, I wanted to run through this. I'm not going to go into a great deal of detail about this, but I wanted to move through this so that you had a sense of what it's like. Evaluation is evaluation. So before the evaluation, some particularities with teletherapy. When you're scheduling, make sure that you allow enough time for the patient to complete and return the initial intake paperwork for your particular setting, if you can. The patient isn't showing up early to complete their paperwork in the lobby. You don't want to spend your evaluation time trying to, ask them questions and complete that whole form when you're with them. Make sure that you send the meeting link and instructions to the patient the day before the session. Keep them really simple. They should be able to just click a link to join the meeting. You need to make sure too that you have your patient's phone number and the phone number of a family member, a caregiver, somebody else who lives with the patient or is near, close enough to the patient that they can get there. You need it not just because your patient may not pick up the phone when you call. You need it so that you can reach another person if the patient needs help. And let's say your patient gets up to go get some water. 5 minutes passes, they're not back. You try calling, they don't pick up. We need to have a number that we can call if the patient disappears and they don't come back to the session. So when you're conducting the evaluation, it sounds stupid, but don't forget to greet your patients and anybody else who is with them. Explain the evaluation flow. You're going to take some initial recordings as you ask them questions, and have them read the grandfather passage. You're going to pause, go through their history, talk to them about intent, and then restart the recording and take some more measures, and then you'll download the recording and talk about it later. If you have Zoom, and I don't know if other platforms are doing this, they've recently started saying, this session is being recorded, and it's kind of loud. And the first time it happened, it really startled me. And if I'm honest, it still kind of catches me off guard. And then when the recording stops, it says the recording has stopped, and it's, I don't know, kind of intrusive. But be aware that that's going to happen. You can warn your patient. A robotic voice is going to come on and say, this is being recorded. You've already told them that, though. So record the patient as you're asking the pre-treatment questions, have them read the grandfather passage. Those resources are on clinical resources. Pause the recording, review their history, train stimulability. You must explain the concept of intent and warm up the voice before restarting the recording. You're doing this even if you see your patient in clinic, right? The only difference is how you're doing the recordings. So restart the recording, finish the stimulability testing, download it. You're going to need to step away for a minute, let your patient know that you need to do that. Usually the download is very, very quick, and then you can queue it up, review pieces of the video with the patient and family. If appropriate, make treatment recommendations, explain the next steps, how to order a workbook. Definitely the online practice sessions, the Parkinson's webinar and information session, and make sure that they understand the expectations. Daily practice, attendance at therapy sessions, follow up with loud crowd, and the online sessions and doing refreshers. It's imperative for them to improve. So this is what our teletherapy evaluation looks like. It's one page. Bear in mind, we do not bill insurance or Medicare. So we don't, we are able to use this form. You may need something more detailed, or if you're in a university setting, you may want your students to do more detailed analysis, and that's good and it's fine. This is a Word document that can be edited. Available in clinical resources at no charge to providers. Before you end the evaluation, make sure you ask if the patient is ready to start therapy. Let them know you'll email them the information that they need. I put our toll-free number on here in case you don't have that memorized. Give them links to our website, the Parkinson's webinar and information session, the Speak Out Parkinson's speech exercises, the Parkinson's lecture series. If you have time, it is a wonderful idea to share your screen and actually show them. This is where this link is. Most of what your patients need can be launched from parkinsonvoiceproject.org. There are boxes that are incredibly clear that tell you, speak out Parkinson's speak exercises. Show them, just all they need to do is click. It really helps them to see it. We are using a modified treatment plan here. When you did the online training, it was 12 sessions. You can do what works for your patients in your clinic. Since starting teletherapy, we find that patients are successfully completing treatment in 8 sessions. So we're seeing them twice a week, but their daily practice consists of exercising with Parkinson's speech exercise session, preferably live, but it can be recorded too. They can watch a recorded session and completing 1 new workbook lesson a day. This is absolutely critical. The patients who do the best are doing both. I don't have any data to support this, but I can tell you after watching patients over the last year, every day, the people who exercise with the Parkinson's speech exercises do better. I surmise it's the modeled practice that really helps them, but it's really motivating. They have chat features. People can interact with each other if they want to. They're fun and interesting. I really recommend it. The other thing is they're infused with education pieces. If you haven't watched one, please do. It's amazing. So home exercise plans, I wanted to take a minute to talk about this. I know you know that home exercise plans are critical. We see our patients for twice a week for 40 minutes, 45 minutes, maybe less, maybe a little more. Even if it was 2 hours a week, there's a whole lot of time in there that your patient isn't being seen. So they absolutely have to carry it over. We need to make voice and speech exercises a daily, lifelong habit. That is the way that your patients don't need to constantly be thinking intent, 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 intent. It becomes a habit. They still have to think about it. Like when I brush my teeth, I have to think about it, right? Otherwise I'm going to be hitting my head or poking it in my eye. So I still have to think about what I'm doing. They still have to think about intent. But the more they do it, the more confident they get using it. And those exercises, if they're walking every day, this is no different. We're asking 15 minutes a day for home practice. They can do this. Those home exercise plans have to be a part of the eval recommendations. You can make it easier and more fun for your patients. Give them forms with check boxes so they can track the online and workbook practice every day. Email them reminders, involve their families. It's really cute because some people who watch the online sessions, their grandchildren are there, their dogs howl. It's really, really cute. Have them set up a home practice station where they can practice the exercises online and in their workbook without interruption. Have them send you a picture. Continue to share the link to Parkinson's, Speak Out Parkinson's speech exercises so they don't have to look for it. Show them how to bookmark it on their computer. So all they have to do is click that bookmark and it opens to that page. And they can set alarms in the AM and PM so they don't forget to practice. Ask them how it's going when you see them. If there are barriers, you don't know what they are unless you ask them. Teletherapy treatment, again, forms are on the website. Make sure you're emailing and texting the links. Helpful tip, keep your volume settings where they were at evaluation. Resist the impulse to turn your patient up. Instead, ask them to speak with more intent. You be intentional. Use the e-library to your advantage and screen share. Involve the spouse and exploit the power of technology. You can video record your patient during the sessions and play them back as teaching tools. It's incredibly helpful. If there are challenges, your patient can't log on or logs in and it's just not working, exit and restart. That's sometimes the fastest way to resolve issues. And ask about and include the home education practice every day. Beat it to death. One workbook lesson, one online practice session every day. Next. You can do things online that are very, very fun. Turn off your volume, call your patient, have them make an informational phone call. Pretend like they're reordering a prescription or ordering a pizza. Have them describe something in the room they're in. Practice using a loud intentional voice. So they're calling to their spouse on the other side of the house. Practice using an intentional, confidential voice. Like they're saying something they don't want somebody to overhear. Use audible reinforcers. You can still use those. They can hear a marble or a coin hitting a cup. Educate, educate, educate. Some people will need extra clinic intent cues. Here are 3 examples. Next of daily treatment forms. Again, you can edit those. Let's talk about discharge. If you used pre-evaluation surveys, send those out so the patient has time to complete and return them. Ask the patient if they'd like their family and friends to be present at graduation. Ask for names and emails. Invite them, send them a link. It's really cute, really fun. During the discharge session, helpful tip, cue up the pre-treatment video, greet everybody, make sure you warm up the patient's voice, record the post-treatment video script, stop the recording, download it, and then share clips. Ask for feedback. Do the final lesson, make that home education program recommendation. They will move to once-a-day practice. I tell my patients, do it online. Do the online practice every day. When I see them in 6 weeks, if they've been doing it, I know. Assign them to a loud crowd if you have one. If not, do the online sessions. Next. After the discharge session, you can email the link to the loud crowd, email the home education program, remind them that part of it is returning for that 6-week follow-up and refreshers. Discharge summary, again, you can edit this. You'll see boxes where we have initial and graduation scores on there so that we can kind of get a sense of how our patients are doing. I just got my 10-minute warning. I have to talk faster. The Speak Out diploma, it's the same whether people are in person or online, available in clinical resources. All right, teletherapy follow-ups and refreshers. The 6-week follow-up and refreshers are necessary. It doesn't matter if you're doing teletherapy or in clinic, you have to do them. The 6-week follow-up, make sure you re-educate that home education program if you've seen they've fallen off the intent wagon. I find that people who exercise with the online videos routinely are much less likely to do that. Use the same scales for refreshers that you used before and compare them to the discharge if you're doing that with teletherapy. Always ask how often they're completing their exercises. I always ask it. I ask it every week at the online loud crowds and ask whether they're doing it with the workbook or online. And you're going to be able to tell. If they're doing it online, they're better. So follow-up form, again, on clinical resources. Ditto for the refresher, you'll see it's the same for teletherapy versus in person. So teletherapy loud crowd. Loud crowd can work great online, but there are some considerations. The first is the number of participants. You decide the upper limit, and your groups may be different. If you have people who are really strong, you can probably have a larger group. But if you have people that need more support, 4 to 6 people may be the max. Consider the makeup of your group. This is no different than you would think about in person, right? You want to put together people who will click. Give your group cohesion by having them generate their own name. We've had some fun names come up. The patient level, you want people to be challenged, but you don't want them to be frustrated. So consider that when grouping them. Send them the link every week. They won't be able to find it if you don't, and it's just easier to send the email out so that they can just click the link. To mute or not to mute? That is the question. It's up to you. I've actually been leaving them unmuted, and it hasn't been too bad. I can turn my volume way down. Next slide, because we can talk a little bit about that. So when you're working with the Loud Crowd workbook, screen share them from the e-library, but be creative. Many activities can be adapted for online reading and cognitive exercises. I've done Mad Libs. You can do kind of Family Feud game show type things. They're very fun. Tap the wisdom of the crowd. If you aren't in the Facebook providers group, please join. In files, there's a page with a list of Loud Crowd activities and a lot of other stuff. So join that group and ask questions. Keep it moving. You want to make sure you move through the exercises efficiently so that they have time to talk at various points. Watch your own speaker settings. If you're going to leave people unmuted, turn them down for the first 4 exercises to reduce that feedback loop, and then turn it back up to a set level for the reading and/or cog. Consider having the group members take turns modeling the exercises. That's really fun. It gives you a chance to see how they're doing, and keep them accountable. I always ask them who's doing home practice. If you're having a particularly wild day, take one of the Speak Out Parkinson's speech exercises and play it for your loud crowd. Let that be your loud crowd. Let them practice with that. It's very fun, and there are some wonderful ones to choose from. So, page full of important links for you. That also cycled through, but those links are there for you. They're all on our website, but these are the ones that well, except for the grants email address and the open office hours, but the others I send out to my patients. Visit asha.org to learn more about providing telepractice. You do need to know the laws in your state. There are some reimbursement issues. I'm not sure what will happen once the government decides that the pandemic is over, but ASHA is lobbying hard to continue to get teletherapy to be covered. Consider recording your own 15 to 30-minute Speak Out practice video, and you and your clinic might be featured on our website. That is a link for that. I will talk more about that in office hours. If you don't come to office hours, you are totally missing it. But the recordings are on the grant dashboard. So if you just kind of want to run it and see what we talked about that day, you can do that. And there'll be a survey question in the assessment of learning about that as well. Many thanks to all of you for helping Parkinson Voice Project fulfill our vision of making Speak Out and Loud Crowd accessible to people with Parkinson's worldwide. We can do that in clinic, and now we know we can reach even more people with teletherapy. So the assessment of learning and the next steps. When the presentation completely finishes, we need you to complete the assessment of learning. It's going to pop up automatically at the conclusion of this webinar. You must complete it. We're actually going to give you enough time to do that. So please, 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 please do not walk away from it. In order to get CEUs, you must complete it. Primary SLPs, after you've completed the assessment of learning, you can log into your grants and click Save and Submit in step 6. You'll go into an admin hold. We have to verify attendance and make sure people turned in their assessment of learning for the ASHA CEUs, and then we'll advance you to the next step, but it will take me some time to do that. And by me, I mean my tribe. So, but we'll be working on that. So grants will be advanced to step 7 after step 6 is saved and submitted, and we've verified attendance and the assessment of learning. Okay, I think that's it. Do you all have any questions?
We had just a couple questions that really is just if you live in a rural area and there you may not have enough people for a loud crowd, where can they find another loud crowd to refer them to?
You know what? That's a great question. So what you can do is go online to patients, the patients and family link, and look at Find a Provider. You may see that there's a provider somewhere in the state who's doing teletherapy, and they may be able to work with your patient. We're here in Texas, so we have pretty broad reach, but there are other people in Texas that may be closer. They may have an in-clinic loud crowd that could see people. The other thing is, I cannot emphasize enough the Parkinson's speech exercises. Samantha goes through, and we have guest presenters from time to time as well. They go through the 6 speak out exercises. It is very, very rare that an actual workbook lesson is learned. There are many, many things that are done on those exercises that are fun and interesting, and they're infused with education. So they're great for your patients if you just can't find a loud crowd right now. And I do recommend, they still need the same follow-up. You still need to do the 6-week follow-up. You still need to do the refreshers, and you may need to make those more frequent.
Yeah, the other question that came in is about doing a hybrid where part of the group will be in person, part will be online. I know I've had some experience with that with our volunteer group.
Mhm.
And I don't think it works that well. I mean, it actually takes longer to set up and everything, but what do you think, Gwen?
I think it's complicated. I also have tried it, and I found that it was just a little bit distracting because, of course, you have to have the camera on the whole group, and you've got the other people up on the screen. So it didn't work as well as I would have thought or would have liked.
Yeah, we don't have any, but that's the neat part about having the Speak Out provider listing where you can find somebody else in the area or the online exercises. Online
Yeah.
exercises are really neat. I think it's great. We've been able to share videos of the vocal folds moving so they can understand the glides better. And it's just going, much better than I had ever anticipated. I do encourage all of you, though, to consider sending in a video of you doing an online session. It can be 15 minutes or 30 minutes or somewhere in between, because we want to have this whole library of more practice sessions for patients to choose from. And we want them in different languages and from different countries. And it's going to be a great resource for your patients and a lot of fun. I mean, imagine they can go on and say, I'm going to do my exercises in French today. That will require a lot of intent.
It really is a lot of fun. And I second that. Make sure that when you do it, if you're doing it from another country, tell them about it. Pick something culturally that is different, because people like to learn different things. And I think that the people who get to watch videos that are from a different part of the country and certainly a different part of the world, it's incredibly interesting, and it's motivating for them.
Well, I think Louise from Australia, hers might get the prize because she submitted an online video where the kangaroos were behind her. I'm not sure if everybody was looking at if they were looking at the kangaroos more than they were practicing, but it was adorable. My husband's a beekeeper, so I'm really tempted to go to the bee yard and do one from there. It would be so much fun. Well, we don't have any more questions, but I thought we could end with one more tongue twister. Again, all the grant sites, once your groups start, once you reach that level in the grant process. If your groups are meeting in person, then you will receive some of these for your loud crowd. If you're not meeting in person this year, then definitely apply for another grant so you can get them. But I thought we'd end it with one tongue twister written by somebody with Parkinson's from Fort Worth, Texas. It says, Millie the milk cow had a monotone moo. She was mad that she mumbled and muttered her moos, which made her mope even more. She made up her mind to move her mouth muscles more to modify the monotone moo. She maximized, manipulated, and maneuvered. She mooed over the moon. Then her speech pathologist helped her with the monotone moo. And now, when Millie opens her mouth and moos north to south, it's may, me, my, mo, moo that comes out. These are so cute. Your loud crowd's gonna love them. And just really grateful to all the patients. And that was one of the activities we did online where we invited everybody to send in the tongue twister, and then each of them will receive one of them. Thank you so much for joining us, Gwen. Thank you for the wonderful presentation, and to Dr. Behrman and Dr. Drake. Again, email grants@parkinsonvoiceproject.org if for some reason you didn't get the handout, but please check your spam and check with your IT department, because if you didn't receive that one, chances are you're not receiving our other emails, and you might be missing out on some fun opportunities like these tongue twisters. All right, thank you so much. We're very grateful to all of you. Bye-bye.